little bit later. So before we dive into today's program, I would like to thank the members of the Planning Committee for all of their help with this. And if you are here, if you wouldn't mind just standing so we can all recognize you. Jennifer Bellhumer, Paul Capuano, Brett Ferret, Tara Higgins, Mary Lavin, Celia McDonnell, Rita Marcoux, Donna Payne, Jane Powasakis, Lynn Pizzulo, Leslie Pyrus, and Michael Simeone. Thank you all for a wonderful job putting this program together. I'd also like to thank all of our supporters. I'd like to say they're all in the exhibit hall, but they're not. Some of them had to leave due to company restrictions. So during our break this morning and during our lunch break, please do visit them and express your appreciation. As I mention all the time, it's the only way we can have this program at Gurney's is with their support every year. So we certainly appreciate that. Before we get started, I just want to call your attention to two points just regarding the technology. We're on an open network here in Gurney's, on the Gurney's Meeting Network. We do have the poll everywhere. We're going to be using that again today. Our moderator this morning will go over those instructions briefly so you can ask questions during the presentations. And finally, a few words about CE credit. The program is being accredited by the by ACPE for pharmacists and ANCC for nurses for up to 7.5 contact hours each day. And you can refer to page 9 of the program to obtain CE reporting instructions, and our moderator will go over those details with you a little bit later. So it is my pleasure to get the program started, and to do so, I will be turning the podium over to today's moderator, Lynn Pizzulo. Lynn is the Senior Director of Quality Innovation at the Pharmacy Quality Alliance. She's a member of the Seminar by the Sea Planning Committee, URI College of Pharmacy alum, and a member of the Dean's Advisory Board at the University of Rhode Island. So please join me in welcoming Lynn Pizzulo.
Thank you, MJ, and good morning, everyone. Those of you who are here present with us in the room and those of you through live streaming. It is my pleasure to welcome you all to the second day of our conference and to serve as moderator for today's sessions. I hope you all who are here in the room had an opportunity to visit with our exhibitors this morning, and then there'll be more opportunities to do so during the breaks and also at lunchtime. So before getting started, I'm just going to cover a few housekeeping items. First, the restrooms are located outside of the ballroom to the right and to the left. We have a planned 30-minute morning break from 10 to 10:30, and that will be in Brenton Hall or in the comfort of your own homes for those of you who are live streaming. And again, be sure to visit our exhibitors and get your bingo card signed. The last chance for bingo cards will be during the lunch, and we will be hosting the drawing right after lunch. CE codes for access to the online evaluation system will be provided 3 times today. The first one will be after demystifying CBD, confusion, hype, and hope, and that CE code will be for 5 contact hours. The second will be after communication breakdown, measles, and the time of vaccine hesitancy. And that CE code will be for 1 contact hour for immunization credit. And the third will be after our last session, strategies for combating opioid-related breathing emergencies, the Community First Responder Program. And that CE code will be for 1.5 contact hours for law. And the codes will appear on a slide at the end of each of those corresponding sections. To report CE, please complete the required program evaluations within 30 days. The CE data is transferred to CPE Monitor, where you can then print your transcripts if that is your desire. And important to note is that the CE data will not be accepted after 60 days from today. So please be sure to adhere to that timeline to get your credit. Questions can be posted on Twitter at URI Pharmacy CPD using hashtag URI SBS 2020 or on Facebook at URI Pharmacy CPD. And next, actually, before I introduce our first speaker, I am going to take us through a quick test run using our poll everywhere. So on this slide here, you see the instructions on how to join. For those of you who participated yesterday, if you have already done this, you should be all set with your texting set up. If this is your first time doing this for this meeting, you can join via the web. You can go to pollev, so POLLEV.com, and then enter the information that you see there on the slide, URI-SBS 2328. And if you prefer to use your cell phone for texting, which is probably the easiest and quickest for you, you first want to text URI-SBS 2328 to 37607. So we're going to give you a test right here. So I'll give you just a moment to get set up on that. And just an additional point, if you're doing it through your phone and texting, once you get yourself set up there with that initial text, you will receive a text reply that says you have joined MJ's group or something to that effect. So you'll know that you're set at that point. So I'll give you a few seconds to do that. And now we already have people responding. So our first question for our test, do you think Tom Brady should retire after next season? I'll give you 30 seconds or so to respond. Wow, almost split. Excellent. So it's still kind of split. So stay tuned. We'll see what Tom does in the coming year. And we also have a really cool feature to create a word cloud. So our next test question is, what skills do you use to treat the whole patient in your practice? And if you would text a one word or a hyphenated word that can then appear in our word cloud, and it can be something that you learned during yesterday's sessions or just something that you're thinking about. This is really cool. Listening. I know that's not always easy for some of us, but critically important. Oh, actually, you can text more than one word if you'd like. All right, excellent. Listening, empathy, and other really insightful words. So thanks, everyone, for participating in our little test. Okay, and with that, it is now my pleasure to introduce our first session, Rhode Island's novel experiment, Office of the Health Insurance Commissioner, and our speaker, Dr. Marie Ganem. Marie Ganem is the Health Insurance Commissioner for the state of Rhode Island. In this role, she ensures the solvency of health insurers, protects consumers, encourages the fair treatment of providers, and works to improve healthcare quality, accessibility, and affordability. The Office of the Health Insurance Commissioner was created in 2005 to oversee both health insurance regulation and health policy for the state. Addressing the cost of health care through alternative payment and delivery models has been the focus of the office's reform agenda. Please join me in welcoming Dr. Ganem.
Hi, thank you. Okay. Thank you. Great. Thank you. Hi, everyone. Podiums are not my friend, so I will be trying to peek around it to see all of you. First of all, I want to welcome you all. It's great to have you and have you spread out because we need you on the front lines, and we don't want any of you to get sick. Secondly, I want to thank Dave Feeney for being here. Dave is one of the advisors. There he is, one of the advisors to our office, and all of this is old hat for him, and hopefully he can be helpful to me answering questions when they come along. But I wanted to say right from the start that we know what is top of mind to all of you, and that is the COVID-19 disease and the outbreak in our state. I'm so happy that Dr. McDonald was able to be here because the health department clearly is the source of truth from the public health perspective in our state when it comes to this outbreak. But I did want to make an offer that if you have any questions relative to health insurance and COVID-19, I'm here and I will help if I can. So I love to start there because I know, as I said, this is top of mind for us. So before we get into what else is kind of in the syllabus today. So think about what your questions are. I can take some now, I can take some at the end, whatever you're comfortable with. Are there any questions at this point in time relative to health insurance and the new disease that we're dealing with? None, okay. So think about it though as we go along. I can at least tell you that our office has been working very closely with our major health insurance carriers. We actually have 4 that are predominantly in the commercial scheme in Rhode Island. So that's Blue Cross Blue Shield, Neighborhood Health Plan, Tufts Health Plan, and United Healthcare. We've also had Cigna and Aetna in our conversations, and as you know, as national insurers, they bring a different perspective, and they also operate many of our self-funded plans in the state. So we have been coordinated in that effort. Similarly, we have included a physician from the Department of Health, the Medicaid program, and Health Source RI in all of our conversations. So the state also has a coordinated approach. You'll be hearing more about that later today. There should be an announcement, if not today, then Monday, about our plans to move forward a little bit more aggressively when it comes to health insurance and health protections for Rhode Islanders. I can give you a glimpse. We have been talking about if there are supply chain shortages, how we handle getting medications to your patients, and how we look at formularies and what is covered and what is not covered on formularies. We are looking at home delivery, refilling prescriptions before in fact the prescription has expired, within, of course, the clinically appropriate and the valid prescription requirements. So there are a host of issues like that we're dealing with the insurers, and again, we'd love to take whatever questions you have to make sure that you're well informed because you're the guys doing the work, so thank you. Okay, so we'll start. Again, just one last time, any questions yet? Okay, great. So the Office of the Health Insurance Commissioner in Rhode Island, the reason why we call it a novel experiment is because we're the only one. So no other state has an Office of the Health Insurance Commissioner. Most states have an insurance commissioner, but they're involved in life insurance and auto insurance and casualty and flood and you name it. And health insurance, of course, is probably the biggest pain in the neck for them, and they will say that. It is complicated, as you all know, and it takes up a lot of their time. And very few of them have an expertise in the healthcare arena, but they do have folks on staff that do. So our novel experiment in Rhode Island has been in place since about 2004, when the legislature decided to create this unique office. They placed us in our Department of Business Regulation, which is, in fact, our bigger insurance regulatory body. And that's great because we use them for financial analysis work that we need to do. They supplement our staff greatly. So it made a lot of sense to do that. In addition to that, at the time the office was created, some of you may remember, we had a couple of challenges relative to private health insurance in our state. We had an entity that was called Harvard Healthcare. Before that, it was Riga. Many of you may know. It was a staff model HMO. So people not only got their health insurance there, but got their health care there. They left the state. They left thousands of people with not only without health insurance, but without a health provider or having to get their health providers elsewhere. At the same time, Tufts was trying to make inroads in the state, pulled out of Rhode Island. They pulled out of New Hampshire at the same time. It was part of a business decision. So we lost 2 insurers. Simultaneously, or soon thereafter, there was a lot of attention being paid to Blue Cross Blue Shield of Rhode Island. At the time, that nonprofit entity did not seem to be behaving like a nonprofit entity, and like the payer of last resort, which we consider them to be at the time. And so the legislature took note and thought that there needed to be changes in how health insurance was regulated in our state, and clearly went beyond the normal role. I have no actual conflicts to disclose, just so you know. Went beyond the, I'm going to flip through this. Sorry about that, here we go. So went beyond the actual role that most insurance departments have, and that is make sure that insurers are solvent. Make sure consumers are protected. That's it. They went beyond that and they said to our office, we want you to not only make sure insurers are solvent, make sure consumers are protected, but please encourage the fair treatment of providers. So that's all of you in this room. Make sure that you encourage policies that improve the quality and efficiency of healthcare services. Look at the delivery system as a whole and try to reform it, particularly with an eye toward affordability and cost. And so we do that. We have a theory of action, and that theory of action includes looking at what our powers and authorities are and then using them to try to advance agendas that we have, reform agendas that we have. And our goals are smarter spending, better care, and a healthier population. So we do that, and with the help of a number of advisors that are on our Health Insurance Advisory Council, like David Feeney, we do that looking at how can we transform care, how can we make payment reform, and how can we contain the cost growth. So in 2008, before I got to the office, the first insurance commissioner actually began to hold the insurers accountable to implement policies to improve healthcare affordability. And the theory is there that we could use the insurers to make change, that we could have the insurers hold accountable some of through their contracting mechanisms, some of how dollars are spent in the state. So I'll go into a little bit of detail as to how we do that. The first thing was, we actually said, let's look at primary care from the perspective of other countries. So when you look across the world and you look at longevity and you look at morbidity and mortality rates, you look at the rates of disease spread through those other countries, you see that they are better off than we are, and that they invest much more in primary care. They spend much less on hospital and long-term care. So you look at that and you say, well, perhaps there's a relationship. There have been studies to show a relationship. You also look at well-performing systems in the United States like Kaiser Permanente, same thing. They put more investment into primary care. So Rhode Island, part of the novel experiment was we were the first state to say, let's drive the insurers to drive more funding into primary care, but not just increasing reimbursement rates. Let's drive it to transform care. Let's drive it to electronic medical records. At the time this started, that was slow. There was slow uptake. Let's drive it toward having nurse care managers in the offices. Let's drive it toward having pharmacists available to work as part of the care team. Let's drive toward longer hours for practices to be open. And let's drive toward a more team-based approach to care. So we put these resources, the insurers, we instructed the insurers to put these resources into a multi-payer collaborative effort to improve and transform primary care in our state. And we've done that. We've seen some of the outcomes. As I've said, we've been doing it since 2008 in the state. Blue Cross did an analysis in 2015, I believe, or at least it was reported 2015, that they saw a return on investment for every dollar they were investing in a primary care medical home in our state, they were getting $2.50. So we're really pleased and really proud that we're working collaboratively to do this. And I'll have some numbers to show you later on too. So we have, as you can see, that's kind of the payment reform is the last on that list, and we've been slow on the uptake there. So we would love to see the next step be, and we've got some new recommendations, new regulations that are coming out, that the investments be in alternative payment models, so that the physicians' practices actually are given the flexibility to do what they want to do without having to bill for every single code, without having to get prior authorization for every single thing they need to do, but are actually incentivized to look at the patient as a whole, to actually treat the patients that need more time with more time, and the patients who need less time with less time, and to get a payment that is appropriate at a capitated level. So again, this is what we looked at. This is just how we use data in the office. What are other countries doing? What are other high-performing health systems doing? And Rhode Island average investment in primary care was about 5 or 6% at the time. And as you can see, we were not ranking so well compared to those others. Also, how we use data in the office, we tracked the office required the insurers to increase their spending in primary care by 1% a year, starting at this time, and you can see what the data shows. So we had hoped to at least be at 10.7%, and we're at about 12. So we've done pretty well, and the insurers are pretty happy with their investment. Here again, just another way to show that where we are today and how that steady increased spending. So as you can imagine, other states have seen this, and other states are now, as of this past year, just this past year, other states are all seeing legislation being introduced requiring a primary care spend in those states. And Chris Kohler, who was our first insurance commissioner, and I have been invited to speak all over the country. I don't go because I think I need to be here, but I'll do some. I went to Massachusetts, but Connecticut, New York, Delaware, Colorado, Oregon, Washington State all have legislation or have passed legislation or have set benchmarks now for spending in primary care and want to learn how we've done it here. I just wanted to focus really quickly. I know there might be some people here from Massachusetts. Also, Governor Baker in Massachusetts did quite a little bit different proposal, and instead of kind of sending a benchmark, has said they want to increase spending by 30% on primary and behavioral health care in our state. And Connecticut has also been working very heavily on transforming their practices. So we're not alone now, but people are looking at us. Just a little bit of our office focuses a lot of time on looking at insurance premiums. So every year we get requests, of course, from any insurer that wants to offer a policy in our state, and we must approve not only what they're asking in terms of what are their scope of benefits and what do their forms look like, but also we get under the covers as to what their premium proposals are, how much they want to charge for insurance. And we have the authority to approve or modify or reject those proposals when they come in. So we think that a combination of what we've done to try to invest in primary care, I'll talk to you a little bit more about what we do relative to hospital costs also, and the fact that we really scrutinize premiums very closely, that we continue to have lower cost premiums than most of the other states in the Northeast. And that's a surprise to everyone because what you see are the high costs you pay out of pocket. What you see and what you hear from is your consumers, your patients, who complain about the high cost of their premiums and what they're paying out of pocket. But at least in the Northeast, we're faring relatively well. Simultaneously, when we're telling the insurers to cut back on spending or to make certain investments in other areas of spending, we want to make certain that we're not impacting quality of care in Rhode Island. We want to make sure that patient outcomes are still as good, if not better. So we keep a very close eye. Again, our focus on data. We keep a very close eye on where we're ranking across the country on some objective measures. So this one, the America's Health Rankings Annual Report, takes 47 different metrics, everything from access to care to patient outcomes, everything in between, affordability, insurance coverage, et cetera. And you can see that although we were at a dip 2012, we have this trajectory that's been going up. And this year, they looked back at data over the past 4 years, and we were the most improved state over the past 4 years. I have to say, I think I attribute a lot of that to the Affordable Care Act, that we in fact have only 4% of our population uninsured, so that there is greater access for folks. And while I know all of the difficulties with getting reimbursement and affordability, nonetheless, we do have a very high rate of covered lives. We rank 7th now in the country on this compilation of 47 different metrics. And you can see that where we were doing well in our rankings and where we were not doing well. So this is probably a good time for me to talk about hospitals. So when you look at what's driving healthcare costs in the state, you probably will look at, well, a lot of our costs are going to hospitals. When you looked back, and I'm going to say almost 10 years ago, when the former first commissioner was in the office, he said, well, if we want to increase investments in primary care, maybe we need to somehow contain the cost of hospitals. So in the private insurance market, what happens is if the public sector, Medicaid and Medicare particularly, don't reimburse well enough for hospitals, then hospitals will negotiate contracts with private insurers to make up the loss. So what happens is if you have a hospital that is so essential to have in a network, use women and infants as an example. What insurance company can have women and infants out of network in Rhode Island? It's not possible, right? Because that's the place where most of the births are. That's the specialty hospital for women. What network in Rhode Island cannot include Rhode Island Hospital? You can't really, because that's our tertiary care facility. So when you have hospitals of strength, hospitals of great value, and they're sitting across the table from an insurer, they've got the upper hand. We need them. We all need them. We appreciate them. We appreciate the work that's done in those facilities. This is nothing to degrade them. But it happens all over the country. Certainly Partners Healthcare in Massachusetts, their health system has a similar level of clout when they're negotiating with their insurers in that state. So what is a phenomenon that happens across the country is that those powerful hospitals are able to garner very high annual increases. And the commercial insurers, those of us who pay for our premiums, those of you who are in businesses who pay for your premiums, you end up paying for that negotiating clout. So the insurance commissioner stepped in and said, we're going to tell the insurers that you cannot increase those contracts more than CPI, and right now it's CPI plus 1% each year. So we're going to give you a weapon, a tool, to take into those negotiations, to say to the people across the table, love to give you more, but we have this requirement, I can't give you more. So what's happened as a result? Yes, in fact, some hospitals have lower profit margins in our state. I will admit that our hospitals are struggling to do facility improvements. I'm not going to say that's a result of our regulation, though. I think it's a result of a compilation of factors. But as a result, we have been able to bring down our healthcare costs in our state. And this is the result. There was an evaluation done by some scientists from Harvard and Stanford that said that we call them affordability standards, and basically it's the cap on hospitals and the investment in primary care, have seen the greatest amount of impact on the growth in healthcare spending of anything that they've seen that a state has been able to do. We actually, according to this study, were able to impact 8% on our commercial spending. So compared to the control group, our actual spending was 8% lower. So these are, again, the novel approaches. No other state in the country does this. Some states negotiate rates themselves. That's Maryland. Other states have other tools that they use, but Rhode Island is unique in approaching it this way. Okay. So one of the other issues that I was asked to speak about today was the importance of mental health parity. And this is an issue that I'm sure you all deal with regularly when you're encountering patients or in your practices or as you're working. What mental health parity is, there are laws at the federal level and at the state level that basically say that we must provide insurance coverage. So parity laws apply to insurance, not necessarily to treatment, they apply to insurance. That insurance must deal with behavioral health, mental health, and substance use disorder treatment coverage under the same terms and conditions that they would treat any other illness. As you can imagine, coming up with comparisons is not always easy. You know, schizophrenia is to diabetes as what is it? So it's difficult always to determine what the same terms and conditions are, but in fact that is up to our office to do, and offices like ours across the country. In 2018, our office completed the first of 4 examinations, and this past week we announced the completion of 2 others that we were doing on health insurance and basically how they were implementing this same terms and conditions when it came to how people access care. And half of each one of these studies focused on pharmaceuticals. So half focused on how, in fact, people were getting treatment, whether it was in hospitals or in community settings. How were the insurers making decisions as to what to cover? What were they denying? What was the level of complexity that patients and providers had to go through to get permission? We did that in the, again, access to treatment settings, but also relative to medications. We asked the insurers to submit a sampling of behavioral health cases. Our office actually collected from Blue Cross Blue Shield over 400 cases in terms of treatment, and I think it was about almost 300 cases relative to medications, and looked at how did the insurer or their third party, and you know at the time I think it could have been Beacon with Blue Cross, but you know there's Optum in the field of RX also. How did that third party vendor, or how did the insurer's responsible, actually treat requests for coverage? What was the process that they made you all go through? How did they respect the judgment of the prescribing physician or the pharmacist in the process of making an approval or a denial? How did they treat appeals or encourage appeals or inform about appeals? And how did the patient fare? Did the patient in fact get the prescription? What did the formulary look like? What step requirements were in there? We looked at all of that in the cases, a case-by-case review. I have to give Blue Cross a lot of credit. And that extends to a couple of other insurers that I can talk about also. But Blue Cross was the first one that we did this study with. They're the largest in the state, so it was appropriate that we start there. They were looking at the same records we were looking at the same time we were looking at them. And not all insurers do that. You would think intuitively they would do that to want to know what the regulator was checking out. But Blue Cross did. And when they saw something that they thought was inappropriate, or that maybe they hadn't dotted all of the I's and crossed all of the T's. And these were records from previous years. These were records from 2014 to 2016. Maybe much of Blue Cross's could have even been 14, 15. They looked back and they said, oh, if we knew then what we know now, we probably would have done it differently. And they started to correct their practices almost instantly. So they didn't wait for us, although we did order a plan of correction, and we did have some other strong recommendations relative to what we found. They started to make corrections right along with us, right along the way. And we have to give them credit for that. So if they saw that they were perhaps, and we did see this with one insurer, perhaps being a little bit unreasonable in approach with a provider, not taking the provider's information, not allowing the provider to communicate well when they thought there should be an appeal and what information came in, they were fixing that along the way. And again, Blue Cross didn't have a lot of instances of that, but we've seen that with other insurers. And I'm sure you see that. So the result of the Blue Cross study was that, again, they made a number of changes themselves voluntarily, but the biggest one that you may or may not know about is that they decided with us as part of our agreement to stop doing utilization review, to stop doing prior authorization for behavioral health providers in our state, if they're in network. So think about that. Think about that. If you are a provider who'd been going through what you know prior authorization is like, they no longer have to deal with that. And that's a big plus. And I'm hoping actually that more behavioral health providers become in network as a result of that barrier being erased. The other thing is we were able to work with Blue Cross as a result of the study to put $5 million into behavioral health prevention in the state, into a fund that the Rhode Foundation is operating. We just finished the studies on Tufts Health Plan and on Neighborhood Health Plan, and similarly found some issues. They have much smaller commercial presence in Rhode Island, and so the result is $330,000 from Neighborhood and $50,000 from Tufts, again going into this pool at Rhode Foundation to help to support behavioral health prevention. You all know that we put very little emphasis on prevention. State governments are not good at funding prevention. It's always the first thing to go when there are budget cuts. So we felt as though this pool of these private dollars would be a helpful investment. So that's what we've done here. We also now, in our state, say that same terms and conditions, right? Primary care, behavioral health care, same terms and conditions. So co-payments should be on par. So if you're going to a counseling visit, if you're going to a medication maintenance visit, whether it's for primary care or it's for behavioral health care, same copay. In the past, those copayments had been specialty copayments. If you were going to meet with a clinician of a behavioral health problem, you were paying $40 or $50 per visit. You were going to see your primary care doc because you had diabetes, you were paying $10. You were paying the primary care level of copay. That had to stop, so we've discontinued that. And then the other thing that we're working really hard on, we have this pilot going and we hope to expand it, is what they call integrated behavioral health. And that is just as you are now a part of teams, many of you are part of teams in primary care offices or in community health centers, we also now are embedding a clinician of the behavioral health care specialty also in those offices. So integrating that care. Very, very quickly, these are just our powers and why we can get involved in behavioral health care beyond parity. We can get involved in designing a system that makes sense for people, and we hope to do that. The last one basically is we can direct insurers toward policies and practices that address behavioral health needs of the public. It's a broad charge. We are probably the only state in the country that has this charge, and we hope to be working with our Health Insurance Advisory Council as to how we carry that out. Just a little really quickly, again, we use data. Clearly, Rhode Island is spending 9 times as much for an individual with complex behavioral health diagnosis than we spend for somebody who doesn't. And compared to national, the commercial in the commercial side, the national example is about 3% more. So Rhode Island is spending more per person with a behavioral health diagnosis than the national average. So we need to address it. So that the data is behind the importance of this work. There are clinical effectiveness studies that show and you can read these yourselves and you'll have access to these slides afterwards, but they can show the savings of not only treating behavioral health, but also treating it in an integrated fashion, where behavioral health providers can assist primary care providers to make certain that people don't get worse, that they get screened, that they get diagnosed early. Finally, again, in Rhode Island, this is a very nice picture of Dr. Alexandra Scott. She is our new hero, the governor, and Teresa Parva-Weed, the president of the Hospital Association. And we are all in this together, and we are looking that we need to do a whole lot to address substance use disorder and mental health distress in our state. So this is the kind of last piece that I was asked to speak about, and that is affordability. And my language now is affordability is in the eyes of the beholder. So if you are a patient, when you consider what's affordable in healthcare, you're considering what's coming out of your own pocket. So do I have to pay a share of my premiums? Do I have to pay a cost every time I show up at a provider? Do I get surprise bills? Do I have an adequate network so that my cost sharing is affordable for me? So is my income going up as well as my premium going up? If you're a business who's buying insurance for your employees, you're looking at your premium, you're looking at what you're getting for your premium, and you're looking at the coverage that you use, right? You're the boss. If you have a small business, you want to make certain that your out-of-pocket is reasonable, as well as you want to make sure your premium's affordable for your business and your bottom line. So you're looking at your profits, you're looking at how much your margin is going up every year, and then you're looking at how much your premiums are going up. From a healthcare provider perspective, affordability means getting adequate reimbursement. It means that your time is valued and that you're not spending it in hassles with insurance companies. We've actually heard in recent years the conversations shift from providers saying we're not being paid enough, look at what Massachusetts and Connecticut providers get, to now they're saying, please, no more prior authorization, please, no more referrals. The paperwork's killing us. So again, affordability is in the eyes of the beholder. In order to keep premiums low, in order to satisfy the employers and the employees who are paying, the insurers are putting these referrals, prior authorizations, and lower reimbursement rates all into effect to keep the premiums down. So our office has this balancing act to ensure the fair treatment of providers and to keep costs down. So we're trying to look at it in a balanced way. First of all, we looked at the changes in federal policy that were coming at us. So you may know when President Trump was elected, soon after, we saw a flurry of activity relative to regulatory changes and even some congressional changes at the national level. So one of the first things that was able to be done, what they were able to do, was to bottom out or zero out the tax penalty for people who don't have health insurance. So they were able to chip away at a very important leg of the Affordable Care Act, basically saying to people, if you don't have health insurance, there's no penalty. So what does that do to a health insurance market? It means all the young, healthy people leave, because now they're not going to have to pay a penalty if they're not in the market. So we saw that as a threat in our state. We saw if in fact the healthy people left, if they stopped contributing to their employer's plan and left the employer's plan, if they left our individual market where they were buying themselves, those markets get sicker and more costly. And then more people drop out, more businesses can't afford it. So we decided we needed to do something about that. There were other things that went on at the federal level, like promoting plans that are very skimpy in terms of what they cover. Actually, there are plans being sold in other states that don't cover pharmaceuticals. There are plans being sold in other states that don't cover mental health coverage or pregnancy, maternity care. Those are called short-term plans in some cases. And so these threats to our system were coming fast and furiously from the federal government. They also discontinued cost sharing, which was going on for people of lower incomes to be able to afford insurance. So we put a group of folks together. We do that in Rhode Island. We do that probably more than other states. We put everybody in a room, because you can do that in Rhode Island. So we get all the best minds we can, or as many of them that are willing to come, put them in a room, and we said, okay, what can we do about these threats? And the group was diverse. I mean, it had business people on it, as well as consumer advocates, providers, insurers, all around the table, and we came to agreement. And the agreement was that at our state, we should have an individual mandate with a tax penalty. Think about that. That's remarkable, that you'd have people from the business community actually saying, yeah, no, we need a mandate, we need to have it, because they saw the adverse impact on our premiums if we didn't. They also saw, gee, that could potentially bring in some money, because the tax penalty at the federal level was bringing in about $14 million to the feds just from Rhode Island. So they said, well, we could bring it, even if we just brought in $9 million, what could we do with that? We could bring rates down. So the other part of their decision was, let's put a reinsurance program together. Let's tell the insurers that if they have some very high-cost cases, we're going to help to offset those costs. So when insurers set premiums for this year, for 2020, they actually knew that they were going to get some help. That reinsurance program was going to help. So in our individual market, where we applied this program and the individual mandate, our premiums came down this past year. So for 2020, Neighborhood Health Plan, actually their premium stayed steady, and Blue Cross in the individual market, their premium came down about 2 to 3%. So people buying their own insurance did not see an increase in their premiums, but a decrease. Overall, this is average. There are some people who saw minor increases. But this is what happens in Rhode Island when we can come together and when we have an office that's focused in this direction. So, as I said, so the affordability, we talked a little bit about our challenges. So again, I'm grateful to David to being on our advisory group because we have to face these challenges as a group. What are we going to do about deductibles, cost sharing? They're killing people, and we need to recognize that. And then the last thing I wanted to mention is that we have a cost target in our state. Another way to address costs, again, put as many people in the room as we could and said, let's see what steps we can take to set a target. And we copied Massachusetts, I'll be fully honest. We're the third state, Delaware came in, and then Rhode Island, to set a growth target. It's not a target that's mandatory, but it's voluntary. We had all the major insurers and our hospital systems. We had Lifespan and Care New England sitting in the room, and they all agreed to do whatever they could to try to meet our target. Our target is at 3.2%. That's pretty ambitious. We know that healthcare costs are going up about 5% or more across the country. But they've all agreed that they will do whatever they can to try to meet this 3.2% goal. We are going to be using data to see and measure if in fact we meet it, and we'll have those first results to report in September of this year. So that's pretty much summarizes that. Should I go back to the original questions? I'll just take questions from the audience. That's great. Perfect. All right. Does anybody have any? Do they come up on the screen? Okay. This is great.
Good morning.
Hi.
You talked a lot about the activities that you did to improve mental health parity, and then the other part being access. You talked about most of the insurers. Have you addressed it with all insurers in the state?
Oh, good question. So thank you. Yes, there are 4 major insurance carriers in the commercial market. We are working on the United Healthcare matter right now. So we should have hopefully results relative to that very soon, but the other 3 are done, and their reports are up on our website. And certainly we found, in terms of access to medications and access to treatment, some policies and procedures that could have been done better to comply with state and federal laws, and as a result we have ordered plans of correction. We've had great cooperation from those insurers that we've completed the work on. And as I said, the United Healthcare matter will be resolved. We hope will be resolved relatively soon. We started a second study. So that first one was on just behavioral health cases and approvals and denials and how those were handled. The second study we're looking now is broader. It's not just behavioral health, but we're looking at network adequacy. So what insurers say in their provider directories, is that really up to date? Is it really accurate? When you look at where the subscribers live, are there access to the appropriate providers in those areas? So that's underway right now for the 4 major carriers also. Well, don't hesitate to be in touch if you do have questions later on. These folks know how to get me, and I'll be available. Thank you. Oh, we got a question. Have you been approached regarding PBM abuses to pharmacy? Okay. Oh, well, there you go. They're right in front of me. Thank you. So let's start with the first one. Have you been approached regarding PBM abuses regarding pharmacy, I guess? So unfortunately, we have very limited laws in Rhode Island relative to PBM regulation. So the other states do have arms of their, whether it's their insurance division or their health departments, who, maybe even if it's just one person, but who regulates PBMs, and so they have the resources to do it, and they also have laws that say PBMs should divulge whatever, they should report on whatever, they should follow certain standards relative to their interaction with community pharmacies and other pharmacists. We don't have those in Rhode Island. So we have very little interaction in my office with PBMs. We hold the insurers, because that's what we do have the authority to regulate the insurers. So we hold the insurers responsible for appropriate behavior of their delegates. So if, and as we did when we did the study, if we do find that the PBM may have been in violation of some policy or procedure, it's up to the insurer to correct that, because that's where our authority is. So I have to say that we have not been able to do much about PBMs to even document if there are abuses or not. Certainly we hear from community pharmacists, and it makes me very sad when I hear of a community pharmacy that closes, and we hear from those community pharmacists just how they unfortunately can't compete in this environment. Again, we don't have a lot of strength in terms of our laws to do much right now. So what's the general history of why behavioral health is treated differently in premiums versus asthma? That is a great question. There has been a lifelong discrimination against behavioral health. I think some of it is fear and lack of understanding, but it is ingrained in our culture. Even calling it behavioral health almost indicates that people have control over it. So the fact, you're a drug addict, you can control that. Well, you can't control that any more than you can control your asthma. Excuse me. I use my hands a lot, I'm sorry. So I think that it's just a cultural thing that we need to get past, that people need to understand that it's okay to have a mental illness, just like it's okay to have a physical illness. It's okay to seek care. And it's really going to be a reconditioning of people's minds to understand that these diseases are diseases and they are not up to someone's behavior. So that's a great question. There is a stigma that exists. I think we're making progress. More people are talking about it, but there's still a general feeling. We even know that it's tough for physicians. A physician with a general practice, if in fact someone comes in for an opioid use disorder treatment, that person may not look the same as the rest of the patients that are coming in. And so there definitely are barriers that we need to overcome. Thank you. What can be done about pharmacy benefit managers? I've just talked about that. They're not regulated, you're right. They mandate pharmacies to, yes, and that 90-day supply issue, we have worked, Dr. McDonald actually has been very, very helpful on that issue because that's been raised by folks in the psychiatric world saying that 90-day prescriptions might be dangerous. And again, Dr. McDonald has been our lead on what's dangerous, what's not, and how can we interact on that, because you're right, we don't have the authority there. Have there been studies done that showed improvements in drug affordability? So the last item that I talked about, that cost growth target, the most important part of that target is that we are putting a lot of money into data analysis. Luckily, we got a huge grant from a private foundation that is helping us to do this work. Brown University School of Public Health is doing the analysis. So not only are we going to say we had a target and we're going to measure whether or not we meet it relative to our growth, we're going to say what's under that, what's causing our growth. We have already done some preliminary look at pharmacy spending, and that is going to be a key component of our affordability review. So where are we spending the monies? Is it in hospital pharmacy spending? Is it retail pharmacy spending? How much is that growing? Where is it going? And so we will be able to have good data. Maybe with that data, we may be able to change some of the laws relative to the regulations. Is there any action being taken toward eliminating high deductibles which discourage senior treatment? So that's the challenge. So when I put up there really quickly the affordability and why we need to have our advisory committee that we're working with, that's a real challenge. Businesses want affordable premiums, and so their brokers are saying, okay, we'll just up your deductible. So the higher the deductible goes, the lower the premium. And that's the mix that we're in right now. And then, do patients need to worry about switching insurance carriers due to pre-existing conditions? And they should not. We do have pretty good laws relative to continuity of care, and we uphold those. And we definitely there. Oh, we got something funny up. Has anyone studied whether the Affordable Care Act saved money, was neutral, cost? So relative to the Affordable Care Act, we have not seen studies. There may be some. Clearly, we improved, as you can see, overall in terms of our rankings in the state, which it covers all of these factors, and we improved dramatically because we have totally embraced the Affordable Care Act in our state. And why should you be bailing out insurance companies when their profits are astronomical? Why am I bailing them out? Mandate insurance companies to provider. So I don't know, we're using penalties. Wow, how are penalties bailing out? I'm sorry, I don't get that. Okay, so the penalties that we impose on the insurers is money from them, so I don't know how that's bailing them out. So that's my response there. So thank you. It's been a pleasure. Thanks. You're welcome. Thanks.
Okay, thank you, Dr. Ganem. Really excellent information. A few things, I'm still really impressed with the work that has been done around primary care practice transformation, and the support that's been provided with technology, adding nurse care managers and pharmacists to build in support for that to build out the coordinated healthcare team. I had the pleasure of being involved in that project from the very beginning when it was an early pilot, and just seeing the evolution and spread throughout the state has just been amazing. And just in speaking, as a pharmacist, I'm just thrilled to see the growth of pharmacists being integrated in the care teams. Also, the OHIC's priorities around additional investments in primary care, and importantly around behavioral health. I think it's very encouraging to see that the impact of the affordability standards that Rhode Island has applied in their efforts and impact on curbing healthcare costs. So really great work. We look forward to hearing additional updates. So with that, our next session, Drug Pipeline and Anticipated Generics 2020. It is my pleasure to introduce Nicole Chesbo. Nicole Chesbo has been working at Prime Therapeutics for 15 years, including 5 years of which have been in the pipeline. In addition to monitoring that pipeline, she works on estimated drug impact forecasting for anticipated high-cost drugs, as well as the anticipated generic and biosimilars launches. Nicole lives in a small town in Minnesota with her husband, 2 boys, and 2 dogs. And when she's not working, you can find her driving her kids to activities and running on the gravel roads. So please join me in welcoming Nicole Chesbo.
Okay, good morning, everybody. Thanks for coming. Like I said, usually I give this webinar, or a similar one, once a month to my computer. So it's very exciting to actually see faces out there instead of my screen. We'll go through those. So we're gonna start with this polling first to see where we're at. What is one drug category that doesn't have any FDA-approved drugs as of now. Okay, it looks like we're pretty spot on. NASH does not have any FDA-approved treatments as of yet. Spinal muscular atrophy does have a couple, and we'll be talking about another one that is in the pipeline. Next one, how well do you know the drugs that may be approved by the FDA sometime in 2020? 100% would have been great, because I could say anything and you guys would be like, oh, great. All right, well, hopefully that'll be a little different at the end. Which of the drug categories below had 0 FDA-approved therapies before last year, but may have 3 by the end of 2020? Looks like we're spot on there. NMOSD is the one I'm looking for on that one. All right, and then the 2 acute migraine agents that were approved, there were 2 in 2019, in December of 2019, and then there was one that was just approved for acute migraine. And we are close on this one. It's changing as we go. This is a little bit tricky because the Vyepti was also very recently approved, but that is for prevention of migraine. So we will talk about that one as well. All of us in this healthcare industry have been lucky enough to have multiple chemistry classes, so I want to know if anybody wants to know a joke about sodium before we start. Nah. All right, so like we said, I'm from Minnesota. I live in Minnesota. I went to school in North Dakota and grew up in North Dakota, and I think our winters are a little different. So to kind of keep this light, I'm going to show you just a few things we do in winters and summers that may be like what you do and may not be. So we live on a lake in Minnesota, and this is what you see usually after school and every weekend. It's lots of cars and trucks out on the ice fishing. You may not know we also do fish fries out there as well as bonfires on the lake. So it's just like a little community out there. And then of course the token fish that you can actually catch if you're not just doing the fish fry and the bonfiring. These are my kids and my husband, real fish. Throw them back in because I do not clean them. Just catch and release. All right, so we're going to get started on recent approvals. The first 2 on this line are the ones I noted were approved in December. So Ubrelvy was approved. That was the first oral CGRP that was approved, and the first new acute migraine agent that's been approved by the FDA in years. And all 3 of these were submitted on the first line close in time in terms of acute migraine, so it was a very exciting thing to go from no new approvals to multiple just in the last couple of months here. Rayvow is the first in-class ditan, so it's different from the triptans it's specific to the FHT1F receptor versus the triptans that are 1D or 1B and 1D. All of these 3 are approved for acute migraine, but the marketing of these is for treatment after triptans fail. Triptans are the gold standard for acute migraine. We've talked to all of these companies. None are looking to replace those triptans, but come in for those people who haven't gotten relief for triptans or cannot take them. They are priced similarly in that Ubrelvy is $85 per tab, Rayvow is $80 per tab, and Nurtec is just around $100. That is an ODT formulation. The others are tablets. And I also wanted to note that Vyepti was also approved. This is an IV medication, and in contrast to the 3 above, it's for prevention of migraine. So it's another CGRP agonist, just like the Ubrelvy, and then the subcutaneous drugs that were approved last year, Amjovy, Emgality, and Aimovig, but this is the first IV formulation. It's given once every 3 months versus the 2 of the subcutaneous are once every month, and one you can give quarterly. They are marketing this to patients who want immediate relief compared to the subcutaneous that might take a week to start working. They say that this is 100% bioavailable and you will get immediate relief. And they also are marketing and saying that convenience-wise, because it's only once every 3 months, but it is an IV infusion. And they all are priced similarly, around $6,900. And when I'm saying prices, I'm always using WAC pricing. And Vyepti is a little bit lower at $6,000, but with the IV administration costs, probably pretty similar. We also saw the approval just last week or the week before of Nexletol and Nexalet, which is the combination of bempedoic acid with azitamine or Zetia. So the place in therapy for these drugs is as add-on to statins or for a person who can't take statins. So they're comparing themselves to the PCSK9s, Praluent and Repatha. They are priced around $3,500 annual cost. They are oral drugs, so compared to the Praluent and Repatha, they do have that convenience in that they're a once-a-day oral drug. In terms of efficacy, the PCSK9s are more effective by quite a bit. If you look at monotherapy, they cut LDL by 18%, and with the combination with Zetia, it's around 40%, and the PCSK9s are around 60%. We'll move on to Vascepa, which is also for CV. It's for secondary therapy to statins to reduce the risk of CV among patients with elevated triglycerides. So you do have to have that triglyceride level of 150 or higher. Patients are supposed to have CV disease or DM, so they didn't get that primary therapy that they were looking for. This is the first fish oil product that was proven in a study to lower CV risk. It had a statistical significant reduction of around 25% in the Reduce It trial, and that was over 5 years. Side effect-wise, there is some atrial fib and some bleeding effects. And when we compare to other fish oils that are available OTC on the market, this is the only one that has that phase 3 outcomes trial showing that it does reduce CV risk. Twirla is for pregnancy prevention. I'm mentioning this one because it's been to the FDA. This is the 3rd time that it was submitted and it finally got accepted. It had to go back and prove that it would stick as a patch to the arm, as well as Xulane, which is already approved. So on the 3rd time it got approved, but this won't be out until 4th quarter. They have 1st quarter, they're gonna work with managed care. 2nd quarter, they're hiring and training people to get it out into the market. And then 4th quarter, they will launch. They are hoping to get around 5 to 8% of the market share. Valtaco was approved for acute seizures. This is from Neurelis, and this is another drug another drug category that just has seen new drugs approved just recently and also coming in the pipeline. So Nasolam was approved. That's a nasal spray of midazolam for acute seizures. And then Diastat has been around for years. It's a rectal administration. So this is another nasal spray, but this is diazepam. That's available, and interestingly enough, the FDA gave this orphan drug status when it was approved, so that means for 7 years, no other drug can come similar to this drug for acute seizures on the market, which affects another drug that's in the pipeline that I'll talk about later. It's quite traumatic. Okay, and then some specialty drugs we just want to mention. Tepezza was approved. This is the first drug that's FDA approved for thyroid eye disease. This showed in studies that the main side effect you have with this is proptosis or eye bulging, and it decreased that eye bulging by 2 millimeters in over 80% of the patients, which is about what you would see with surgery, which is usually employed to decrease that eye bulging. It's an IV therapy. There's a total of 8 infusions, and they're given every 8 weeks. It uses weight-based dosing. So when you figure that out for an 80 kilogram average adult, that's around $450,000 annually just for those 8 infusions. but it has shown to be effective in that primary endpoint of eye bulging. Palforzia has gotten a ton of press, obviously. It's the first peanut desensitizing agent that has been approved by the FDA. It's for A-immune, and it is an oral capsule, or it comes in a sachet. It has to be opened, and you have to put it on semi-solid room temperature food and then eat all of that food. It's essentially just peanut powder. But because it is regulated, this is now FDA approved. We've asked the manufacturer how it differs from just using a little bit of peanut butter, and that answer is that it is a regulated dose. So it is very labor intensive to get regulated on this drug. Updosing is all in the office with a doctor. It's 5 different dose increases. It takes about at least 5 hours to do. And then after that, it's 11 updosing again over every 2 weeks of trying to get to that 300 milligrams of this peanut powder. Once you get to that 300 milligrams, then you can take that by yourself, but each updosing has to be in the doctor's office as well. The main thing to know with this drug is it does not mean you can go eat peanuts, which I think the press didn't originally focus on so much. I think a lot of the parents, if you listen to the FDA AdCom, were thinking that this is a drug that they can just start taking and then their kids can eat peanuts. No. The studies show that they looked at patients that could tolerate about a third of a peanut without having a reaction to start, and by the end of a year of taking this, they could tolerate anywhere from 2 to 4 peanuts without having a reaction in about 67% of patients, and that compared to about 4% of patients in placebo. Of course, there are still people having those reactions, and so that's what the main issue is here. If you follow ICER, they noted that it's not nearly as safe as just avoiding peanuts, and certainly not as expensive, because this is around $11,000 WAC annually. Trifecta was approved by Vertex. This one was interesting because it now covers 90% of the CF population. Prior to this approval, we were covering about 60% of cystic fibrosis, so this added another 30%, or if you look at the numbers, around 18,000 it now covers of cystic fibrosis in the US. It does have a superiority study against Semdeco, where it came out ahead in a 4-week study in improving FEV1. Reblozyl, or if you say it really quirky, it sounds a lot like red blood cell, Reblozyl. This is from Celgene. It's for transfusion-dependent beta thalassemia. This is for people specifically that need 8 to 12 or 12 to 17 transfusions a year. So it's for those just for the transfusion dependent, which is about 1,000 people in the US, whereas beta thalassemia that's not transfusion dependent is around 10,000 people. This is a subcutaneous injection that is given every 3 weeks. It has to be given in a healthcare office, not because of safety, but because they need to check those red blood cells before they give it each time. This is around $170,000 annual a week. So this is a smaller population than what they're going for in April. They already have an SNDA that will be decided upon the FDA in April, and that's for MDS. So that's really what you're seeing a lot of these orphan drugs do, is they go for a smaller population, and then they come in with an SNDA and get a much bigger population. Givlaari is for an Al-Anon, and this is for acute hepatic porphyria. Again, this doesn't have a FDA-approved drug as of yet. In the past, it has been treated with prophylactic panhematin. That is also what you use for acute hepatic, or for when you have an acute attack. So their thinking here is that now you are decreasing the amount of those attacks and you won't have to get as much hematin. So this is around $575,000 annual WAC, which they said is less than what you would pay if you use prophylactic panhematin, which is around $400,000. And then you're decreasing those acute attacks. And then another category where we haven't seen any approvals much lately, and Dari was approved a few years ago for sickle cell disease. And now we had these two that were both approved almost back to back right in December, but they are different, at a different population within the sickle cell disease. Advil is from Novartis. This is to reduce the frequency of vaso-occlusive crisis. So this actually has an outcomes study that found that it decreases the amount of these vaso-occlusive crises from about 3 to about 1.5 per year. And about 40% didn't have any of these crises that were treated, and about 20% in the placebo didn't. So that's over only 1 year, and they think that that will be bigger as we go through that. Oxbrita got accelerated approval, so it doesn't have an outcome study. It showed that in I shouldn't say small amount, about 50% of patients, it increased the hemoglobin by 1. And this is an oral, so they also differ in the fact that Advil is for an IV administration, oral, every day. Oxbrita, that's $125,000 annual WAC. IV is about $113,000. Will they be taken together is the big question we all ask ourselves, and there's nothing to say that they couldn't be, and there's also nothing to say that they will be better taken together. So just because this can get a little heavy and kind of can feel like it goes on forever, I'm just gonna keep on showing you stuff about Minnesota. So this is the closest thing I could come up to a pipeline, because it's kind of looks like we're wakeboarding, but my husband takes out the snowmobile and my kids snowboard behind. And I take pictures, because I do not do that. So we'll move on to allergy and respiratory, and this is the first part of the pipeline. We have bronchitol. This is the second or third time that it's being seen at the FDA. It would be the first time that mannitol is available in an inhaled inhaler versus doing a nebulizer. Hypertonic saline is already used for CF in this way, looking at the same primary endpoint of decreasing that mucus. Viaskin peanut, so we already talked about Palforzia, which was approved. This may be less intensive if you want to think about it that way, because it's a once-a-day patch. So that first time that you put on the patch, you have to be at a healthcare administrator's office to make sure that you don't have a reaction. After that, you just change your patch every day. So it's a little less labor intensive in terms of having to put that peanut powder on something and then make sure you eat it all every day. In terms of efficacy, the patient populations were a little different, but if you compare them, this one looks to be a little bit less effective. It's about 40% of people didn't have that reaction when they had 2 to 4 peanuts, but in placebo it was about 13%. So if you remember Palforzia, it was around 67%. But they are thinking, so Palforzia would be a little more effective, and this might be a little more safe. But the takeaway here is that they really are not what you would call safe. You can still have these peanut reactions. You absolutely have to carry EpiPen on you at all times, just like you would if you didn't use these. So it's not something you can take to just eat peanuts. Filgotinib is just another JAK inhibitor, if you want to look at it that way. It's there are already a few on the market. This one is starting with rheumatoid arthritis and then also looking at other autoimmune diseases as well. It's going to be a little bit more hard for them to get market share when there's already JAK inhibitors out there. Probably similar in efficacy to the other ones. Gilead was hoping that this would be the more safe option, but that hasn't been proven as of yet because they're not going head-to-head with these other drugs as of yet. Ozanimod kind of missed the boat here. It was at the FDA first. Mayzent was going to be the one that got approved second, but Ozanimod got a CRL, or refused to file, which meant that the FDA wouldn't even review it yet until it went back and redid some parts of its submission. So in between that time, Mayzent got approved. They're both SP1 receptor modulators. They both work similarly. They're looking like they have the same efficacy, same safety, but Ozanimod is going to get approved afterwards, so whether or not it will be able to take some of that market share from Mayzent remains to be seen. Arzera I put on here. This is already available in an IV formulation, for cancer, but now they're looking for a subcutaneous formulation. This is one of the Cortellis list 11 drugs to watch in 2020, and this one was on there. So usually I don't follow or put on a pipeline that has NDAs as much, but because this is supposed to make more of a splash, this is included. It's looking only for the relapsing MS. It's going up against Ocrevus. They feel like that's the patient population that they're gonna get people to come over to this one, because about a third of patients will switch every year on their MS drugs. So they're hoping that they're gonna get those Ocrevus patients onto this. This is a subcutaneous auto-injector. Ocrevus is given IV once every 6 months. So Novartis thinks that the auto-injector self-administrator is gonna be more convenient, and that's how it's going to get a lot of these patients, versus Ocrevus, where you have to go into a healthcare administrator's office and get this IV. So convenience is, I guess, is in the eye of the beholder. There, Azera also has a lot of injection site reactions. 50% are having those. So again, convenience, kind of determined by how you tolerate that. Inebilizumab and satralizumab, they are both for NMOSD. So back in June of this year, Soliris, which is already approved, had the first drug that was FDA approved for this disease state. And now there's 2 coming in the pipeline that are looking. They have a slightly different indication in that they are going to be able to treat patients with AQP4 IgG antibodies. Soliris can only treat patients with those autoantibodies. That's what the indication is for. Both of these drugs can treat the whole population of NMOSD. So Soliris is covering about 75% of those patients. This would cover all of that population. They're also looking to get market share by their efficacy data is around 70%. We'll have less relapses. Actually, it's closer to 80% with both of these, 77 for inebilizumab and 77 to 78 for satralizumab. Similar in efficacy, there's very similar patient populations. The big difference here again is going to be convenience. Soliris is IV every 2 weeks, inebilizumab is IV every 6 months, and satralizumab is subcutaneous every month. Again, getting a little heavy, so I bet you're wondering how often I will tell chemistry jokes. Periodically. I realize these are corny, but it does help break it up a little bit. We have the combination of celecoxib and tramadol trying to get approved in pain. The FDA just had a pain advisory committee back in January where they did review this drug. And this is one, at least they didn't completely shut down. They voted 13-13 for approval. So some said yes, some said no. Mostly they said this offers no advantage over the 2 separately. Tanezumab, this has had quite a bit of press too, off and on for years. It would be the first nerve growth factor for pain. It's a subcutaneous nerve growth factor for osteoarthritis. The big thing here is hoping that it would be better efficacy than, say, opioids or to be used after acetaminophen and NSAIDs. The efficacy data, I shouldn't give an opinion on. So the 5 milligrams met 1 primary endpoint in its study out of 3, and the 2.5 did not meet any of the primary endpoints out of 3. And then they thought that this would be safer. But back in 2015, they actually had to put a clinical hold on these studies due to possible joint damage and osteoarthritis. So hopefully we'll learn more about how they have overcome this, because obviously those studies did get back on the books, and now they have them. They at least take down 1 primary endpoint out of 3 in their studies. And then I'm not going to say too much about naloxone because there's more to come later today. This is for opioid use. The difference here is that this one would be an 8 milligram dose versus the ones that are currently available are up to 4 milligrams. I only have one that I'm following in CV right now, secondary prevention in arterial sclerosis. Again, we're comparing them to the PCSK9 inhibitors. This is a subcutaneous injection. It's twice yearly dosing. So again, this convenience factor, hoping to come to market. They have this new mechanism of action for this disease state, and that's a RNA inhibitor. So it's different than the PCSK9 inhibitors, but still work to prevent that PCSK9 production. Hoping for convenience factor here, the weakness here that they don't have compared to the PCSK9s is that they don't have that CV data, that outcomes data, and that's not going to be available until 2024. So breaking into this market may be a little bit difficult. Under CNS, we have a few. Desantraline is back at the FDA. It originally was looking for ADHD indication. It got a CRL on that. The FDA went back and said they need to have more clinical trials on that one. Now they're coming with moderate to severe binge eating disorder. This is usually treated first line with cognitive behavioral therapy, and then after that with pharmacotherapy, not FDA approved, but often used SSRIs, antiepileptics as well. Olanzapine and sandomorphin, those are put together in a combination for schizophrenia and bipolar disorder. This sandomorphin is there to help decrease the weight gain that you see with olanzapine. This is the second time, actually, or third time that this has been at the FDA, hoping for an approval this time around. And then donepezil in a patch is looking to be approved for Alzheimer's disease. Aricept and generics are available. This would just be a different formulation. Take a break again. This is what we all feel like in March in Minnesota. We have a little hill on our driveway. We often use it because we're often getting just drenched in snow. This may be how we all feel about the coronavirus as well. Just out of our control. In dermatology, we have just a new strength of minocycline in a foam. A topical foam was approved by the same company for acne and Amzeeq. This is a lower strength formulation. This is 1.5%. The acne is 4%. And then we have Winlevi, which would, if approved, be the first anti-androgen approved for acne. Androgens increase around the menstrual cycle. This would help to work against that. Looking for both men and women, though, for acne. Ycanth is quite interesting, I think. It's for Musculum contagiosum, which sounds a lot like something you would hear in Harry Potter. Just red bumps all over. It's a viral infection. It happens to many, many people. Around 6 million people in the US will get this. A lot of times people will even get it and not get the red bumps. So it's just a very contagious viral. They last for a long time. These bumps, they're not usually anything other than that. They may itch at first, but oftentimes they're just this really annoying red bumps all over your legs, your torso. You can, right now, go to a dermatologist's office and get them burnt off with cantharidin, which is what Ycanth is. They're just now looking to be able to have any office you could get this at, or possibly even do at home. It's beetle juice is what it is. It's from a toxic beetle, a toxin from a beetle, and it's just known as a burn agent. So essentially just burns these red dots off. If you don't do that, they will go away, but it can take 12 to 18 months. And then we have very similar to Botox, but you would have to do it less. You could do it every 6 months versus every 3 to 4 months. And pegliflozin, 2.5 milligrams for type 1 diabetes. I wouldn't bank on this getting approved because it just got a 1412 opinion from the FDA AdCom for type 1 diabetes. This is not the first SGLT that is looking for approval in type 1. There was another one, Zynquista, back last year that was looking for an oral in type 1 diabetes that did not get approved either. I'm not saying this won't. I'm just saying they had an FDA AdCom that voted against it. Usually the FDA follows, but they don't have to. And then you can just strike this one off. This just got a CRL on Tuesday before I flew out. It's from Intarcia. I won't talk about it because it just got its second CRL. It's a subcutaneous mini pump. You would only have to get it in the doctor's office every 6 months. So it's the same thing that's in Bydureon, but you'd only think about it every 6 months, but now you don't have to think about it until it comes back to back to the FDA. April in Minnesota, we see less snow, but our basketball court is the last part that will melt off because of sun. So if you look closely, you can see that my husband is desperate. He has a small snowblower out there, and then my son and his friend are desperately trying to shovel it off. And right after this was last year, it was 2 days later, we got a huge storm. It started all again. And they even knew that was gonna happen, but they did get to play for a day. So moving on to endocrine. This was another approval that just happened, so this is actually not in the pipeline, it's in approvals. Istura was approved for Cushing's disease. This is usually treated with surgery, and around 77% will be cured and will not have Cushing's disease after surgery. So these are for those patients who either cannot have surgery or have relapse after that surgery. It's an oral drug, and there's already other drugs that are available. Just specifically, they use ketoconazole for this, or metoprolol for this as well. They're just not FDA approved. This is, when you look at it, very similar to metoprolol or ketoconazole in that it inhibits steroidogenesis, or making of the steroids, but those are taken around 4 times a day, and this is an oral once daily. So hoping to get that convenience market share again. Mycapssa, convenience again, it's a 505(b)(2), just piggybacking on sandostatin's efficacy and safety, but this would be the first oral option of octreotide. Vivarimer from Tricida is for metabolic acidosis in patients with chronic kidney disease. In terms of efficacy, this is looking for accelerated approval, so it just looked for the levels of blood bicarbonate after 12 weeks, whereas we have shown that sodium bicarbonate has decreased the progression of CKD. So this is just looking for that accelerated approval. They'll have to go back and finish their phase 3 study that they have started for this one. Then amphora, this is a vaginal pH regular. It creates a hostile environment for sperm to live. It uses lactic acid, and it can be compared to other vaginal gels. This is a big one. This has gotten a lot of press already, and it's going to get even more press in the years to come. For NASH, there are no FDA-approved therapies as of yet. This is Ocaliva, but it will have a new NDC, it will have a new drug name. So this is actual NDA, it's not an SNDA, piggybacking on those, that efficacy and safety. This is the first drug that has shown a decrease in fibrosis in these patients, but there are about 10 drugs in the pipeline now, 2 closer to getting to the FDA. So we'll be hearing more about that. This is supposed to be about a $25 billion drug class by 2025. So this is just the first of many to come. This is a very specific population, and in that it's looking for those patients that have fibrosis stage 2 or 3, but not cirrhosis as of yet. And that looks like what the population will be for most of them. There are generics like pioglitazone, I'm sure you've heard, that can be used for NASH. That's usually after lifestyle managements are not working. Same with vitamin E as well, but they just don't have that FDA indication as of yet. They do have some efficacy and safety data in certain populations. Triheptanoin is from Ultragenyx for long-chain fatty acid oxidation disorders. This is an oral drug. This is most commonly, this is an orphan drug disease state. So if you think orphan drug disease, you think pretty high pricing. Right now, this is treated with fasting, low-fat, and high-carb diets, or carnitine has not much good information. But medium-chain triglycerides are a medical supplement. So you can get these over the counter at a health food store. Around $50 a bottle is what Amazon told me. When they did these studies, they had people discontinue their MCTs. So about 90% of patients are already on it, and in this patient population, there were 90%, and they had them discontinue, and then they call this UX007, against placebo. And so even though it was efficacious in decreasing the amount of attacks in these patients, we don't know where those MCTs fit in, or if this should be used after or concurrently. So that remains to be seen, and I don't know when we will have that data, but it is orphan drug disease 8. So it will definitely be more expensive than MCT oils that are used as of now. Gimoti is just a 505(b)(2), piggybacking on metoclopramide's or Reglan's efficacy and safety information. It's a nasal spray, so it is hoping to be useful in the patients that can't take the oral tabs. Its bioequivalent has been shown in studies. So what do you get when you cut an avocado into 6 times 10 to the 23rd pieces? Guacamole is correct. Nailed it. So that will lead us into a much heavier topic with hematology. I will try not to talk too much about Valrox here, because I think I could probably talk for an hour on this one. This, if approved, would be the first gene therapy for hemophilia. Patients that were in the study had severe hemophilia, so factor VIII, less than 1. In the patients that have been treated with this, which are not a lot, but that have been treated, you're seeing an effect in these patients in that they are no longer having bleeds, and in most of them, they are no longer using factors for that first year. We have data out to 3 years that has been provided to us by BioMarin, and we see those factor levels go. It essentially is a gene that takes care of the deficiency. It teaches your body to make factor yourself, so you're getting up to levels of 60. So you were less than 1, and now you're at 60, which is beyond mild hemophilia. And then each year after that, they're seeing the factor fall. And that's what they're trying to figure out, is what factor does the factor fall. So you're seeing it go 60, 30, and down depending on what assay they use. Right now, BioMarin is saying that they believe this will be effective at least till 8 years out. So most gene therapies you give once and done. Right now, they feel like they can say this will definitely work for 8 years. But that is exfoliated data. They do not have that yet. They're hoping to give the year's data, 4-year data soon. Big thing here is that BioMarin started saying that the US population is very used to paying $2 to $3 million for a gene therapy. And now, with more data coming out, it does seem like maybe it could be even higher than that. So very excited to see what happens there. That does have a PDUFA date in August, so we'll learn a little bit more there. Relentis is a Neulasta, similar to a Neulasta. It's a long-acting compared to the other drugs on the market. Subcutaneous injection, 505(b)(2), nothing too exciting there. Bereltrostat is from BioCryst Pharmaceuticals. If approved, this would be the first oral therapy. So again, convenience factor. We have Takydro and Haegarda. Those are subcutaneous injections. And then Cinryze is an IV infusion. Those are all for the prevention of attacks. This is also for the prevention of attacks. May in Minnesota is heavy lifting for us. We farm, and it used to be a lake area years and years and years ago. So every year these gigantic rocks come up. So most of May we're picking rock, which, who picks rock? Apparently we do. I did not know that when I got married, I'll tell you that. All right, oh yes, and then we go into some more heavy stuff here. Neuromuscular. Risdiplam is looking to be the first oral therapy from Genentech for SMA. And they're looking for SMA type 1, 2, and 3. That's what their pivotal study's on. Zolgensma is for patients with SMA less than 2 years. And Spinraza is for anybody with SMA, but is mostly used in that patient population of 2 or 3. So when you look at the marketing of Genentech, you look at their efficacy and safety, they're looking for that Spinraza market share because they work similarly. They both work on the SMN2. But again, convenience factor, a lot of people are not comfortable with giving their kids Spinraza because of its intrathecal administration. This would be an oral that you'd give every day. Now, I don't know, I kind of think, well, it's oral every day, but this is going to be, Spinraza is $375,000 annually. We assume this will be very similar. And what if you spill it? It's an oral, I always think of that, so it could be more expensive, but I bet people will be more careful than that. For lamotrigine, this is from Eton, another oral liquid. It's similar to the tabs. It's just that this could be dosed down to 1 milligram versus the 5 milligram, which is available now. Fintepla, if you've seen that fenfluramine before, you have. It's back from the 1990s in the fen-phen. They are looking to treat kids with Dravet syndrome now with fenfluramine. They have said that they haven't seen any of the CV issues that were seen in the past with fenfluramine. Libervant, this is the one I kind of alluded to in the approval section. This is for acute seizures as well. So Veltaco just got approved, Nasolam got approved, both nasal sprays. This is an oral buccal film. The interesting thing here is that Aquestive, back in December, petitioned the FDA with a citizen's petition saying, essentially, please don't approve this drug before ours. They said Veltaco doesn't have as many studies as they do, and they should go back and have to have as many studies as they do before they approve it. In response, the FDA approved it and gave it orphan drug status and 7 years of exclusivity. So now Aquestive is saying they have submitted it, the FDA has accepted it. It's quite possible that the FDA will approve it, but they won't be able to launch for 7 years. Don't fall behind, I guess, in your studies is what that means. Opicapone, this is just a CMOT inhibitor similar to Comtan. This is a once daily, and Comtan can be 3 to 4 times daily or anytime you take levodopa carbidopa. Apomorphine, this is similar to Apokym. Apokym is an injection for OFF episodes in Parkinson's disease that is known for its nausea and vomiting after the injection for OFF episodes, but also its very high efficacy. This sublingual tab is not as efficacious when you look at the studies, but safety-wise and the nausea and vomiting that you would get from this is much lower. So, what are you looking for? Lots of efficacy or safety? I am not an oncology expert, but I wanted to include these for thoroughness sake. If anybody has questions on these, I am more than happy to try to answer them, but for brevity and thoroughness, this is a slide, and I'm not going to go into it. Same with these are just all oral oncology. You're seeing these get approved all the time, all have niches, all have, third to fourth line. Repetitive is fourth line. Tucatinib, I think, is third line. Not going to say more than that. June in Minnesota looks so much better and probably a lot closer to what you do here. Lots of lake time, lots of fun in the boat time. That doesn't really translate back to oncology, but didn't think of that. So I will just mention these just because, again, just the amount of press that these drugs get. The CAR T therapies were approved a few years ago. That's when patients, they'll take out your blood, they will keep the T cells, they will modify the T cells with a chimeric antigen and put it back into your body, and then that will then target the tumors. So we had 2 approved a few years ago, Yescarta and Kymriah, and those were for diffuse large B-cell lymphomas. And now Yescarta is looking for SNDA in mantle cell lymphoma. And then we have JCAR017, which is looking for a similar indication, large B-cell lymphoma, as the other 2. And then we have MorphoSys coming in with tafasitamab, which is what they're hailing as an off-the-shelf CAR T therapy. So it targets the similar CD19 on the tumors that the CAR T cells do, but it's readily available. You can take it right off the shelf. So it doesn't work in exactly the same way, but same target. Could be a lot, I shouldn't say that, could be cheaper and could be more safe because CAR Ts have a lot of different issues that go along with that. Real quick, we'll just say Instiladrin, this is a gene therapy, but not really, because this usually you give a gene therapy and then you don't have to give it again, or at least not for 8 years if it's hemophilia. But this is one that you would actually give every 3 months, and it helps the body make interferon 2B. And then the reason that they don't want you to always make that is because hopefully you don't always need that extra interferon 2B. This, they have said, we met with the manufacturer, that it will be priced similarly to Keytruda, and there's another drug in the pipeline that's not quite far as long in this one, but Keytruda has this exact indication. It would be priced similar to that and not a gene therapy in the millions. I think we'll go on from there. And ophthalmic, this again just approved, Bimatoprost sustained release. This is an implant for glaucoma, and you only can use it twice. You get it once in one eye and once in the other eye. This is for convenience sake. It works similarly to Alumagan or the drops, but more convenience. You don't have to think about it once you have it. But then you can't have it again because of safety issues and losing some of your, I think it was color cells in your eyes. So depending on if you can or can't take those drops, this could be an option. For oxymetalazone, it's from Vertical. This is just using an OTC formulation, or using oxymetalazone, which is available OTC, and then putting an indication on it called acquired blepharoptosis, if I say it right. Usually it's surgery, it's for droopy eye. It doesn't have an FDA-approved indication, but you can get oxymetalazone OTC. And then we have a neurovascular macular degeneration drug. There's already quite a few other drugs. This is looking to have fewer injections than the others that are already on the market. More like fun. I just want to point out, you probably can't see that, our neighborhood is almost exclusively boys. I don't understand it, but I do know that we have multiple little mats like this, and all they do is just wrestle out in the water, and we get to sit on the boats, and we do not wrestle. So whatever works. In generics, I'm not going to go through each and every one of these. I just want to point out some of the big ones that are possibly coming. But again, for thoroughness sake, I wanted to put them in. And then I noted just generic exclusivity in terms of, is it coming out with just one manufacturer or multiple? If it's one manufacturer, you'll usually see that 6-month exclusivity. And that will be about a 10 to 20% decrease from the brand. And then once that exclusivity runs out, around 6 months, you'll see that 50 to 80% decrease from the brand name products. I'm not going to note anything on that one. Oh, hey, this one is all about delivery. 2 men walk into a bar. 1 man orders H2O, and the other man orders H2O too. He's dead. Okay, so Byetta not used as much once Bydureon came out, but that is looking to go generic. That, and then Proventil, this one has been on our pipeline for quite some time, but it is hoping to come out in the 2nd or 3rd quarter. I did put these on earliest expected, so earliest expected would be May. Durezol also has 177 million in US sales. That's about a 50% chance that one comes out in May. June is more of a blockbuster possibility month. Dexilent is a $1.1 billion US sales drug. But that, when we were looking at that, earliest possible, again, is June, but it could be out to 2023 due to some patent litigation going on. And that's the same story for the next couple. Eliquis, there are already 2 ANDAs approved. Earliest possible would be June, but due to some court decisions that have to come through, it could be 2026. So earliest June. Forteo, this also is a almost $1 billion US sales drug, 940. This is probably a second half sometime. We've had this on the pipeline for years. I'm sure you've seen in the press different things they've tried to do to make sure that this does not get a generic. This is what we have it sitting at in June as of now. There is one 505(b)(2) that is approved, Sequa is what it's called, but it isn't therapeutically equivalent to Restasis. July, I don't know if you've heard this, but if you live in Minnesota, you'll hear it, $250,000 right before July 4th. They'll always say, got to make sure the corn's knee high by the 4th of July. So it helps if you send out little kids to make sure that that's working, and then you take that picture. Okay, nothing, oh yeah. Yes, Pomalyst is a big one. This is a blockbuster. This is a $1.3 billion US sales. That one has 5 manufacturers waiting to come out with that in August. Really? I'm already there. Okay, good. Here, another play on words. So I'm a pharmacist by trade, but when we get to harvest season, refer to myself as a farm assist, which really just means I ride around on the tractors with everybody else. And I bring food sometimes. This is them all driving around in tractors. We got sugar beets, soybeans, and corn. If anybody wants to talk to me about that, I have a phone. You can call my husband. Don't know anything. We do have a couple HIV looking to go generic in September, Truvada and Atripla, both blockbuster drugs. And then Tecfidera. Oh, you could go on and on and on and on and on about the patent litigation. I won't. You're welcome. On this one from Biogen, it's probably around 50% chance that this would actually go generic. Patent litigation would move this, depending on whose side they go on, could be 2028, so early as possible. And then there has been some press, I don't know what kind of press I read versus what kind of press you read, but there is Beferitam was approved last year. They are a 505(b)(2), so not therapeutically equivalent, but similar to dimethyl fumarate. They got a tentative approval to start. And when you get tentative approval, to change that over to approval, you just have to send in a sheet of paper to the FDA and say, yep, we're ready. We want that full approval now. Usually they wait and do that until patent litigation is done. Patent litigation is done. They actually won, and they are able to come to market. Why they haven't come to market yet, we haven't quite figured out. Usually, or to get that full approval, then they can come to market. They could launch any time, but they haven't sent that piece of paper in yet. Usually that's due to manufacturing or looking for a partner. That doesn't seem to be the case. So this could possibly go any day. But again, that's a 505(b)(2), not exactly the same. October, we're all still super happy. We're harvesting. Everything's going great. November, you're still harvesting. It's not going great. You don't even want to be harvesting in November. Usually you aren't. This year, a lot of people were harvesting in December and January. We did finish up, but that's what it looked like. The big one here is, well, both Dulera and Chantix, they both have chances to come out generically, but for Dulera, there isn't a competitor that's actually applied for an ANDA, so it kind of have to wait for a product to come out. And then Chantix is, again, this is patent litigation issues. It could be November 2020, and it could be moved out to 2022. Okay, so we're almost done, and luckily enough, we have fourth quarter. We have a field that we refer to as the fourth quarter, and we'll go into fourth quarter. So this is the second half. I only did this in case we had time left, which we're almost out, so I'll just mention these. These are drugs that are not, actually that's not true. Roxastat just last week, I believe, got a FDA PDUFA date, but it is in December. The rest of these are all hopefuls. They hope to file this year, also hope to get an approval this year, but if they don't file soon, we're not going to see these approvals this year, but close into 2021. Roxastat and Vadustat, they're very similar. They're both looking for indication anemia of chronic disease. If approved, they would look for market share from the ESAs, or erythropoietin stimulating. This would be the first oral, so whoever gets that would have the first market share. Interestingly, so Roxadustat does have a PDUFA date now. Vadustat just, I don't know if they bought it or they applied for a priority review voucher, so that would jump over the PDUFA date of Roxadustat. So that could be very exciting. Vitilarsen is a similar patient population to Vyondys 53, so it's IV also. Nothing really distinguishes it there. Lentiglobin would be the first gene therapy for transfusion-dependent beta thalassemia. So if you remember way back in the approvals part of this, this would be for that same population, so around 1,000 people in the United States. What they're really looking for is in their phase 2 studies, they're also looking for sickle cell disease. So that would be the first gene therapy for both transfusion-dependent beta thalassemia and sickle cell disease, which is a few years out. 2022 is when we're expecting that filing. This has not been filed yet, and now we thought it would be filed early this year, has been moved to the end of this year. So at earliest, it would be a mid-2021 approval. PTC AADC is an intracerebral gene therapy. They actually go into the brain, they do it through MRI, and they drip in this gene therapy to treat AADC. This again has that motor milestones that are never met in babies. They did show us videos when they came in for a clinical, and sometimes that really backfires because you'll see something not work and you'll watch the video and you can't see it work. This you could actually see these babies go from not being able to meet any motor milestones to walking and running and riding a bike. So efficacy-wise, this is very interesting. This is a very, very low group of patients. There's around 200 possible treatments or patients in the US and Europe. So very few people would benefit from it, but every person that they have treated has met those major milestones. And then lastly, I won't say much about this one, aducanumab. This has been in the news, as all Alzheimer's disease drugs have been in the news, not necessarily because they work, but because everyone's trying to find a drug that does work. These phase 3 studies originally didn't meet their primary endpoints, and then they went back and looked, and now Biogen has a patient population in the Alzheimer's disease group. If you treat them early, they're saying that that is efficacious. They say they will be filing sometime this year. We hope to see more data from them as well, because that originally in May of this year was going to be discontinued. So we'll find out more. I bet you're wondering why I won't tell any more chemistry jokes, but that's because they're all, I gotta say right, because all the good ones are gone. So we'll just finish up. We'll go through and make sure that we can answer these questions now. How well do you know the drugs that may be approved by the FDA in 2020? Don't be afraid to hit that C. Oh, come on. Oh, well, yeah, there's a lot of them. I talk fast. Hopefully we hit on some of them that are interesting. Okay, what is one drug category that doesn't have any FDA-approved drugs as of yet? Yep, NASH is the answer there. Which of the drug categories had no FDA-approved therapies before June of 2019? Oh, look at you guys. Yay. That was right. Okay, 2 acute migraine agents were approved in 2019, and then one more was approved. What is the name of it? It's A. A. There we go. Nexletol is the drug for cholesterol. Oral drug competing with the PCSK9s. Thank you very much. That's it. Does anybody have any questions?
Thank you, Nicole.
Yeah.
So my question is about the CGRPs. Do you know if it's been studied, if you could use the acute therapies and the preventative therapies at the same time?
So that is the question, and that is what people are looking for. I don't know that they're doing those studies. I think that it doesn't make a lot of sense to prevent something and then treat it with the same mechanism of action. And I believe our PAs, our prior auths, are saying that you can't use them together. But again, there's not necessarily information saying you can use them together or can't use them together. But in general, you would usually want to prevent with one mechanism and treat acute with another mechanism, which is why we have the PA. Okay, thank you. That's a really good question. So, yep, what we use is called Pink Sheets. That is our major source of information. It's through a subscription. and it shows all the FDA drugs that have been submitted as well as accepted by the FDA that for those companies that want it to be known. So any publicly owned company will release those dates, and oftentimes a private company won't. So that's why you'll see approvals come out of nowhere where nobody was talking about it. That's because they weren't listed on that. So we use Pink Sheets, which is right from the FDA. And then we also use a couple other subscriptions. IPD Analytics lists those drugs very similarly. And then we also use Cortellis, which is another subscription where we find a lot of the information about these drugs and their PDUFA dates. And then as soon as we know they've been accepted by the FDA, we start ordering those clinicals from the pharma companies so we can learn as much as we can, especially for these ones that we are considering that they'll be high cost. Oh. Ha! Thank you. That means you've been watching the slideshow. I'm so excited you looked up. What is my favorite part of Minnesota? So I guess I actually do love seasons. I love that our summers are very hot, and I love that our winters have snow. Now, I did not say I love that they're freezing cold. The other day on Monday, I walked my dogs. It was -10. I mean, why? But I love snow, so I love skiing. We have a ski hill half-hour away. And I love our summers. So I guess I could take or leave spring and fall, which also is planting and harvest, so you can see how invested I am in the farming situation.
Thank you so much. Thanks so much, Nicole. Really great insights into the pipeline, and I have to say I am always impressed by and so appreciative of individuals like yourself who focus in these areas. I know it's hard for everybody to keep up on everything that's coming out, so these types of sessions get us caught up really quickly, so appreciate all of that. Also, the pictures of your family and fun in Minnesota. Maybe I'd come out and do some of that snowboarding behind the snowmobile, but I don't know, chilling on that mat in the lake sounds pretty good to me too. So again, thank you for that, and I might even try out some of your jokes. I laughed at every single one. My family might throw me out if I try them, but I think for our pharmacy friends, we can certainly appreciate the humor, so thank you. So next we are going to take a break that will carry us up until 10:30. For those of you who are here with us, feel free to go next door into Brenton Hall for the breaks and refreshments. I think some of our exhibitors might still be there. If you want to get your bingo cards initialed or signed, and then you can leave them at the registration desk. Again, the drawing will be after lunch, so you want to get those in soon. Those of you who are live streaming with us, feel free to take your break at home, and we will reconvene at 10:30. Thanks so much. Okay, well, welcome back. I hope everybody enjoyed their break. I just wanted to give one quick programming update before we move into our next presentation. Unfortunately, Valerie Moritz from the DEA is unable to join us this afternoon, but we do have a substitute presentation, so we are lucky to have, for our last session of the day today, Dr. Anita Jacobson will be presenting strategies for combating opioid-related breathing emergencies, the Community First Responder Program. And that also will have the 1.5 contact hours for CE for law. So just wanted to provide that update. And next, I am pleased to move us into our next session. Let's clear the air. Vaping is not the alternative. And with that, it is my pleasure to introduce Dr. Jamie McConaha. Jamie is joining us virtually, so I will be advancing her slides for her here, but you all will be able to see Jamie in the slides. Dr. McConaha is an associate professor of pharmacy practice at Duquesne University School of Pharmacy in the Division of Pharmacy Practice. After graduating from Duquesne, she completed a 2-year academic and teaching fellowship with the school. Upon completion of her fellowship, Dr. McConaha joined the School of Pharmacy's clinical faculty. Her teaching and research interests focus on the role of the pharmacist in ambulatory care, specifically with the disease states of diabetes, COPD, and tobacco cessation. In 2013, Dr. McConaha developed and implemented the Duquesne University Tobacco Treatment Specialist, or TTS, training and certificate course. Since its inception, the course has graduated over 1,000 TTSs from across the country. And most recently, this course has been incorporated into the required pharmacy curriculum for the school. Dr. McConaha practices in the field of ambulatory care, and for the past 10 years, she has worked as an embedded pharmacist within 2 primary care physician practices. In this setting, Dr. McConaha offers a variety of clinical services for her patients, including medication therapy management appointments, transition of care consults, and group tobacco cessation classes. Dr. McConaha developed and teaches a group smoking cessation class to patients of her practice and also throughout the greater Pittsburgh community. She has published on topics of electronic nicotine delivery systems and has spoken on this topic at the local and national level. Additionally, Dr. McConaha serves on the board of directors for Tobacco Free Allegheny and was recently elected to the office of Secretary of the Association for the Treatment of Tobacco Use and Dependence. With that, please join me in welcoming Dr. Jamie McConaha.
Thank you. Hi, everyone. Can you hear me okay? Okay, perfect. Happy Friday the 13th. I am so sorry that I can't be there with you live. Unfortunately, we had a last-minute travel restriction from my university, so I was not able to come out to Rhode Island. I was very disappointed, but I'm grateful for the opportunity to still get to speak with you today. So the presentation, as you heard, is called Let's Clear the Air. Vaping is not the alternative. You could advance the slide. I have no conflicts of interest to disclose. And my learning objectives are listed here. So the first 2 learning objectives, we're really going to talk about ENDS. So ENDS is the abbreviation for Electronic Nicotine Delivery System. So we're going to talk about what makes up these products. And then we're going to spend some time talking about the changes in the regulations surrounding ENDS. And then lastly, I hope to discuss a little bit about our role as healthcare practitioners in providing education and recommendation to these patients who may be using these products or trying to quit their use. This slide. So we will start with a fun question here. What year did the FDA last approve a new smoking cessation medication? Okay, I see some couple of responses coming through. 06, 08, 2002, 97, 2006 again. Okay. All right, let's go ahead and advance the slide and see the answer to this one. So the answer is 2006, and that was Chantix or varenicline. So the question remains, is it time for something new? And I think that when the e-cigarettes and these ENDS products came to the market, a lot of people thought these could be the new solution or our new product that was used for smoking cessation. But as you can probably tell, spoiler alert from my title of this presentation, they are not. And we're going to talk about why that is. So I wanted to begin with some basic terminology. So as I mentioned, ENDS stands for Electronic Nicotine Delivery System. And that is an umbrella term that really encompasses any of these electronic products. So you can see some examples listed on the slide. That's going to be your e-cigarette, Cigalikes, vape pens, hookahs, or e-hookahs, excuse me, etc. When someone uses an e-cigarette, we call that vaping, or the person using it is called a vapor. The solution or the cartridge of solution that goes into these products that can contain nicotine or not is referred to by several names, such as e-juice, e-liquid, vape juice, etc. And then the last row there that says mods is a particular type of ENDS products. It's short for modification, and they're larger electronic devices. And I'll be showing you some pictures of those coming up. So just as a background, before we begin speaking about our e-cigarettes, to compare them to traditional cigarettes, I have the components of a traditional smoked cigarette on the slide here. So you can see in the middle that traditional cigarettes are filled with mostly tobacco leaves. Those tobacco leaves are a reconstituted product treated with nicotine and up to 600 different additives. We always get the question of, why are all these additives in a cigarette? A lot of them we don't know, but some of the reason has to do with absorption of the nicotine and also flavorings. You'll also see, if you look at that picture on the left-hand side, that there's a paper wrapped around those tobacco leaves, and it's made up of 2 different thicknesses of paper. And as the cigarette burns, we get what's called a burn ring. And the reason for these is to control the rate of burning of the tobacco and also to keep the cigarette lit when the user is not actively puffing on it. You'll also notice at the tip of the cigarette are ventilation holes. So these were originally designed to allow additional air into the cigarette with the thinking that this would lower the tar and the nicotine that was given to the user. But what we find is most smokers cover those ventilation holes with their fingers, so it really doesn't do anything in terms of a risk reduction. And then lastly, a filter was added to cigarettes, and that was added in 1954, really as a way to, again, make it a healthier or safer form of smoking. Again, we know that there's really no evidence that decrease our risk of smoking. Slide. So our first true question here, which of the following is true regarding e-cigarettes? Is it A, in the US, the nicotine components of e-cigarettes are highly monitored and kept to an acceptable range? B, electronic cigarette companies are required to label their products with accurate nicotine concentrations? C, newer generation e-cigarettes use nicotine salts to be able to deliver higher concentrations of nicotine than first generation e-cigarettes? Or D, vaping has been suggested as a preferred smoking cessation method in adults over the age of 18. I'll give it a second for some answers to come in. And it looks like the majority of responders are answering answer C, which is the correct answer. I realize the way that D is worded, it says vaping has been suggested as a preferred smoking cessation method, and maybe that's true from the manufacturers of e-cigarettes, but it's definitely, as you know, not an FDA-approved cessation method and nothing that any of the health organizations recommend. So yes, C is our correct answer here. So I introduced here a case study, and we'll revisit this after we get through the talk. A patient of yours has struggled with smoking cessation for 5 years. She typically smokes a pack per day, and she's tried every available nicotine replacement therapy with no success. She presents to your clinic excited about her new e-cigarette, which has helped her cut back to 5 to 7 cigarettes per day. She asks for your opinion on e-cigarette use. So this is a case, a real life case, and I present this when we teach it to our students at Duquesne, that we see a lot of times. So again, when e-cigarettes first came to the market, a lot of adult smokers thought that these would be a great smoking cessation aid. And in that regard, you know, well, again, we're going to talk about all the harm of these, but is it safer than cigarettes? That's what we're going to talk about. But I really think the issue becomes that we're seeing younger, you know, high school and middle school age students use these devices who were not previously smokers, and are they really acting as a gateway to smoking? So again, we'll come back to this and see if the talk changes any of your opinions on how you might respond to this patient. So just to give a brief history of e-cigarettes, you can see actually a person from Beaver Falls, Pennsylvania, first filed a patent for an electronic smoking device in 1963. So if you are familiar with any of like the U.S. Surgeon General reports or anything like that, it wasn't until 1964 that we had the first U.S. Surgeon General report that really said smoking was bad for your health. So this Herbert Gilbert was really before his time. Unfortunately, his patent for this electronic smoking device never really took off. You know, he was a little bit too early. People weren't interested at that time in an e-cigarette. In 2003, however, we had Han Leek, who was a 52-year-old pharmacist in China, develop the first e-cigarette. And what was interesting was this pharmacist, his father was a heavy smoker who developed lung cancer. And so this pharmacist developed the e-cigarette as a healthier alternative to smoking. So originally it was developed with good intentions to help as a smoking cessation aid. So in 2006, we saw e-cigarettes become available in Europe. And then in 2007, they started making their way to the United States. Slide. So as you will see on the upcoming slides, these products vary widely. And I'm going to go through the different generations of e-cigarettes. But in general, they have a similar anatomy that is shown here on the slide. So the majority of the e-cigarette is made up with the battery. Most of these products today are rechargeable, although there are disposable ones on the market as well. Next to the battery, there is going to be that microprocessor, and there's an atomizer. The atomizer contains a heating element, usually a metal coil, that heats the liquid component in that cartridge. It turns then that liquid component into a vapor, which is what then the user breathes in. So again, we're going to look at some of the different generations, but this is just the overall anatomy of what these products contain. So our first generation electronic cigarette, when they first entered the market, they were intended to look like a traditional cigarette, as you can tell from these pictures. We also call these first generations cig-alikes. Oftentimes they are disposable, just like a traditional cigarette, although there are some cig-alikes that are rechargeable as well. And some examples that come to mind would be like the blue e-cigarette, which is a rechargeable cig-alike. Slide. As e-cigarettes got more popular, their design evolved and they got further away from the traditional look and feel of a traditional cigarette. And we started to see these larger pen-shaped devices. And these larger e-cigarettes were rechargeable. And because of that rechargeable component, they became more convenient for the user. So our third generation e-cigarettes, these are what I was referring to earlier as a mod. So again, mod just means short for modification. A lot of times you'll see users that use mods be the hobbyists, as we like to call them. So they, it's a hobby, really. They get very into customizing these products, making them their own designs, things like that. I've even seen mods that were an old Nintendo game controller that turned into an e-cigarette. And I'll show you some other pictures coming up. So these, as you can tell, are much larger. They do have a rechargeable battery. And when we saw this third generation come on the market, they became refillable with the e-liquids. And so this is where we really saw the flavoring of these products begin to take off. And that's something that we're going to talk a lot more about when we get into some of the newer regulations and how that's changed with flavorings. And then lastly, our current or newest generation of e-cigarettes is our 4th generation. And the switch here has really been to sort of a high tech or a sleek appearance. Again, these are easily rechargeable. Usually they connect to a USB cord. And they contain most of the time a disposable pod, which is shown in that picture at the top, that's filled with the e-liquid. I have some examples listed on the slide. Juul really dominates the market. It's over 3/4 of the market of e-cigarettes right now. But some other examples are Sorion Drop, My Blue, and Vuse Alto. So this is, even though these kind of look like mods, these are some examples of 4th generation e-cigarettes. It constantly amazes me. So this is obviously a huge area of my research and teaching, and something I'm very passionate about is smoking cessation and studying the effects of these e-cigarettes. And I'm constantly amazed by the new design and appearances I see on the market. It seems like there's always a new one every day, and it's really hard to keep up. But going from the slide left to right, the one on the left that has those 4 standing together, that's the Sorion Air product. The one next to that, the blue one, is Sorion Drop. Next to that, you can see is actually a vape watch, which is something pretty interesting. So you can have students in classrooms really have that pod like right on their watch that they can vape from. And then the one at the top next to the Lamborghini symbol is called a Rolo Badget. So as I mentioned, smoking cessation, smoking, and e-cigs are constantly evolving. And what was just approved at the end of 2019 is something called IQOS. And that stands for I Quit Ordinary Smoking. They also call this a heat not burn system. So they say that what you're doing is a tobacco heating system. This is brand new. It's not available in all states. Right now, it's only available in 2 US states, but I suspect this will be something we see everywhere very quickly. And the concept behind this, again, this is from the tobacco industry. I always say sort of like the evil tobacco industry, but they say that this product heats, as it says, and doesn't burn your tobacco. So they say traditional cigarettes burn at about 600 degrees Celsius. This product heats the tobacco only to about 350 degrees Celsius. And they claim, therefore, that it's smoke-free and that the user is not inhaling any smoke or ash. So again, this is being marketed as a healthier form of smoking. And really, this resembles what we have seen, among history with the tobacco industry constantly trying to modify their products and come out with safer alternatives. So it goes back to, adding the filters in 1954, coming out with light cigarettes, low tar cigarettes, then the e-cigarettes, and now this is the newest thing coming to market, this IQOS. So are these heated tobacco products, including e-cigarettes and that IQOS that I just showed you, are they less harmful than regular cigarettes? Hopefully, again, from the title of my talk, you can guess that the answer is no. And I have on this slide some of the rationale. So the first box there on the left says that although the aerosol that we get from these e-cigarettes does generally have lower levels of harmful ingredients, it doesn't mean that they're safe. So when I have patients that come to me and they ask about these e-cigarettes, particularly I work mostly with adult smokers. So these are patients using these as a smoking cessation device. I tell them, puff for puff, these products probably are better than smoking, but that doesn't mean that they're safe. Doesn't mean that they are, exempt from any of these health issues. And so again, what we don't want is people that have never smoked to use these products and initiate into smoking. We also don't want patients that maybe would have quit smoking switch to these and continue to smoke. So you can see the next box says research suggests they still contain many of the same harmful ingredients. We do, of course, need additional research on this. And again, these products are not FDA approved and they're not a smoking cessation method for quitting. Remember, like that first quiz question, our last approved smoking cessation medication was Chantix in 2006. Next slide. So you guys answered correctly my question about the nicotine salts in these e-cigarettes. So I wanted to look a little bit further into the liquid and the nicotine components of these products. So the earlier generation e-cigarettes contained what we called a free base nicotine, but our newer products are now using a nicotine salt. So what does that mean? As it says on the slide, the nicotine salt allows higher concentrations of nicotine in the e-liquids and a more effective delivery. The reason it does that is it has to do with lowering the pH of the liquid, so the user can take in more of that without any, or with less irritations. There's still some, obviously, throat irritation. So this is, of course, problematic because we're getting patients getting much higher levels of nicotine than they would get from smoking a traditional cigarette. So again, that's going to be bad for our patients who are trying to quit smoking because we're keeping them addicted. It's also going to be very bad for our patients who never smoked because now not only are we getting them addicted to nicotine, we're getting them addicted at a very high concentration. And then as that last bullet point says, the amount of nicotine found in e-cigarettes is very variable and the labeling is not always accurate. Now I'm going to be speaking in a little bit about some of the changes in regulations and how we are going to see some changes in the labeling of these products. But what's on the market right now, the label does not often match the amount of nicotine. So e-cigarettes are traditionally labeled the cartridges as no nicotine or nicotine-free, and then low, medium, and high levels of nicotine. But what we're finding is that studies have shown that some of the cartridges that say no nicotine really have high levels of nicotine. And the ones that say medium have low, and ones that say no have some, and things like that. So again, when you compare this to an FDA-approved smoking cessation device, such as nicotine replacement therapy, the premise is that we're going to taper down their nicotine over time and eventually get them off of that. If you have patients using these products where the amount of nicotine is highly variable, it's not helping them taper off, but rather it's feeding that addiction cycle and keeping them in using these products. So I'm sure that we have all seen in the news the emergence of vaping-related illnesses. And this has obviously recently been somewhat overshadowed by the coronavirus, but I actually am going to talk a little bit about how they two can be related here. So we call this EVALI. So that stands for e-cigarette or vaping product use associated lung injury. So anytime I use the word EVALI, I'm basically talking about a person that has used e-cigarette or vaped, and now they have some lung injury or death. On this slide, it's actually already outdated. It says reported in 49 states with 39 confirmed deaths. That number is now higher. It's 50 states, the District of Columbia, and 2 U.S. territories, so it's everywhere. And the number of deaths, the last statistic that I saw was 53, but again, it's hard to keep up. That number is always climbing. So what is causing the lung injury with these products, or what is, the mechanism behind this EVALI? Most of the current cases have been linked to patients using cartridges that contain THC. So it's not to say that those using non-THC cartridges can't have EVALI, but that has really been the association that has been found so far. And in particular, it's been vitamin E acetate in those cartridges that has been linked to the pulmonary injury. So there's ongoing cases that really suggest the use of e-cigarettes causes injury to the small airways of the lungs. And these are associated with an increased susceptibility of inflammatory lung illnesses such as pneumonia. We've also seen that human cells that are exposed to e-liquids are shown to have a decreased viability. So again, that leads them to an increased risk of bacterial and viral respiratory diseases. So as I mentioned, I wanted to sort of relate this to coronavirus. I was, reading a little bit just this morning, and there have been studies of non-smokers who were exposed to e-cigarette aerosols, and they were found to have a decreased cough sensitivity. So what some of the newer, again, this is very new, obviously, but what some of the hypotheses are right now is that comparing that reduced cough sensitivity with the impairment in the human ciliary function that's been shown in animal studies, that combination, you're not getting some mucociliary clearance. It can really, again, increase pneumonia risk and increase the risk of other bronchospastic types of diseases. So now there have been some hypotheses relating, do smokers and do e-cigarette users in particular have higher risk of coronavirus or other types, again, of broncho diseases. Now, going back to this slide, though, so we're looking again at this vitamin E acetate. It's mostly been seen in cartridges of THC. The CDC does say there can be other ingredients that can be contributing to these recent hospitalizations. But at this point, that's really the one that has the strongest evidence of being the issue. I did want to add that so far there have been no studies linking e-cigarettes to cancer, but a published study in 2019 suggested that mice that were exposed to e-cigarette aerosols did develop lung carcinoma. So my own personal opinion is that it's probably a matter of time before we see these studies in humans as well. Okay, slide. So I gave a very similar presentation in January, and when I gave this presentation, there was an EVALI update that just been published, and this came out on January 7th. There has not been another full report such as this, which is why I left the slide to say January of 2020. But as I mentioned, these individual numbers are increasing. So these EVALI updates are put out through several organizations, including the CDC, the FDA, and then state and local health departments. And what they do, they're really keeping tabs on the number of these EVALI cases. And as I mentioned previously, now we do see these in all 50 states, DC, the US Virgin Islands, and Puerto Rico all have EVALI cases. You can see the number there says 1,979 patients with data available. Again, that number now is higher. It's around 2,500. And of the patients experiencing EVALI, the majority, as you can see, 82%, reported using a THC-containing product. So again, that's really where we're seeing the strongest link. And then what's interesting, if you look at the bottom part of the slide, those patients that had EVALI that were linked to a THC-containing product, where did they get these products? So you can see commercial sources was only 16%. So commercial sources includes recreational dispensaries, medical dispensaries, things like that. But the bulk of the people are getting their products from informal sources, which means family, friends, or dealers, either online or in person. So slide. So why did I point that out, in particular where patients are acquiring these things? So as we all know, and as I've mentioned a few times, we're really concerned about the use of these products in our younger adolescents. So you can see that adolescents ages 13 to 17 are more likely to get products, whether it's THC or just nicotine-containing cartridges, from informal sources. So you can see 94% acquired that from informal sources. So again, that means family, friends, online, things like that. So why, again, am I pointing this out and why am I stressing this? So when we talk about the regulations, how much is that really going to impact what these kids are able to get their hands on? And that's, we'll talk a little bit more about that when I get to those slides. Okay. Go ahead and slide. So this is just really a recap of everything that we've talked about thus far. So the THC containing products from informal sources have detected vitamin E acetate in these products. You can see FDA did testing on 73 EVALI patients. 79% had at least one product test positive for THC. And there have been recent studies that found vitamin E acetate in bronchioalveolar lavage fluid in 94% of EVALI patients. So again, this is just really re-stressing what we already said, that a lot of this lung injury seems to be linked to that vitamin E acetate. So the ENDS products produce an aerosol. So when I showed you the image of the anatomy of an e-cigarette, we said that there was an atomizer. It was usually a metal coil, and that heated the liquid and turned it into a vapor. Now, if you talk to a proponent of an e-cigarette, they'll say it's just a water vapor, it dissipates, there's no harm in it. But what we're finding is that that is definitely not the case. So the aerosol that comes from these products does contain nicotine, but it also has other particles that are problematic as well. So if you look at that second bullet point, it says aerosol from vaporizers can contain metals from the heating coils. So some heavy metals have been found in studies in this vapor, including cadmium, lead, nickel, tin, copper, etc. And there's reports then that inhaling these metals can cause cardiovascular injury, and it can affect your resting heart rate and blood pressure. Of course, we do need longer term studies to determine long-term cardiovascular risks. But again, I'm just trying to prove that's not an inert substance. You can also see that leave it on the slide, sorry. We do have other cardiovascular concerns as well beyond what I have listed of this slide. So there is in this aerosol a creation of carbonyl compounds. And this is created when the solvents in e-liquids, which are usually propylene glycol or glycerol, when they are heated, those are also shown to increase the risk of blood clots and atherosclerosis. We also have flavorings in these products. Again, a big source of debate right now, but the flavorings themselves can be harmful to the user. So cinnamon in particular has been shown to cause significant cell death compared to other flavors. There's also some concern that when people mix these flavors or use different combinations, that they can be more toxic to cells than just using one flavor at a time. And that's something that surveys have shown that a lot of adolescents do, is they sort of create their own flavors in these products. And we see them do those not so much with the pods, like the pre-filled cartridges, but when they get from the vape shops and things like that, the larger, like the refillable type of cartridge solution, each solution. Okay, slide now. So I've pointed out a lot of concern with these products health-wise. So we talked about EVALI, which again is the e-cigarette or vaping associated lung injury and deaths. We said that's been reported basically in every state. We talked about the cardiovascular risk, the risk of the flavorings. And then this slide just has some additional risks as well. So there has been an increase in calls to the U.S. Poison Control Center with ingestion of these e-liquids. And again, this is something that we worry about if people have young children in the household or pets or things like that, if they get their hands on these e-liquids and ingest them. And I'll show you in a few slides, and I'm sure most people are familiar with, the variety of flavors that are currently on the market, which of course will be changing, and how they can mimic candy and be very enticing to children. Other health disease states, there was a case report of an 18-year-old who developed hypersensitivity pneumonitis after 3 weeks of vaping. We also worry about what we call popcorn lung or bronchiolitis obliterans, and that is in the bronchioles of the lung, injury and inflammation. So all of these things linked to e-cigarettes. So again, just really trying to paint a picture of all of our health concerns. Okay, slide. So not only are we worried about all these health concerns, but we also worry about these things exploding. So, you know, they don't light like a traditional cigarette, but again, most are battery operated, and we've seen the stories or, you know, I've heard the reports of these things exploding. You know, I've seen very graphic images, which I didn't want to include in today's presentation, but there have been reports of people who were driving using their vape. It exploded, caused them to wreck. You know, these things cannot be because of airline restrictions into checked luggage, which I'm not quite sure how I feel about that. I don't know if I really want them on the plane at all, but again, just pointing out all of the bad and the issues with them. Okay, slide. So where are we today? The vaping epidemic. So as I've mentioned a few times, we're really seeing an increase in the prevalence of vaping and e-cigarette use in high school and college age students. So e-cigarette companies are going to market their products saying that they're safer. They say that they have less toxic chemicals, harmful chemicals than a traditional cigarette, but hopefully I've pointed out to you that these are not safe products, and there is a lot of harm with their use. Okay, slide. So I've mentioned that we do have, this is getting into my second learning objective, a lot of changes in regulations. And this is going to be really interesting for the e-cigarette market. So I wanted to talk about that, but we'll start with a question on the next slide. Which of the following statements regarding government regulations of ENDS is true? Is it A, all manufacturers of ENDS must register with the DEA? B, new tobacco products require a pre-market review. C, ENDS products may not be sold to those less than 16 years of age. Or is it D, all of the above? I'll give it a second, let people answer here. Okay, so the majority of people look like they answered C, but we have some answers for D, a couple for B. So this is somewhat a trick question, I'll be honest. So when I wrote this, the correct answer was going to be B. Because of our changing regulations, we do have new products now requiring a pre-market review. However, answer choice C is technically correct as well. With our new regulations, and we're going to talk about this, the regulations are now 21 years of age. So technically 16 falls under that 21 age. So that would be correct. Answer choice A, though, is not correct. So with the new regulations, the ENDS products register with the FDA, not the DEA. So that is why answer choice A is not correct. So we can say B and C are both true answers. Go ahead, slide. So just to give a little bit of background about our regulations to show what has changed and where we are today, on June 22nd of 2009, President Obama signed the Family Smoking Prevention and Tobacco Control Act. What this did was it gave the FDA the authority to regulate the manufacture, distribution, and marketing of tobacco products. And then you can see on the slide what was included under this act. So that included cigarettes, e-cigarettes, roll your own tobacco, and smokeless tobacco. So what obviously was missing would be the e-cigarettes, because remember, they really just came to the US around 2007. So go ahead, slide. So in 2016, we had an amendment to that original act. And what it did was it extended the FDA's authority to all tobacco products. So now we see this rule extending to e-cigarettes as well as cigars, hookahs, and dissolvable tobacco products. So you can see now under this new rule that all of these products required health warnings, and it also banned free samples. But because of this new rule, something that's not listed on the slide, manufacturers of newly regulated tobacco products that were not on the market before February 5th of 2007 would have to show that their product met the applicable public health standards that were set by the FDA. And so I point that out because it's really important to note that virtually all of our e-cigarettes were not on the market before that date. So again, e-cigarettes came here in 2007, so they weren't really on the market before February 15th of 2007. So they had not yet gone through this review. So that means that really they should have to go through an FDA review to determine whether or not, they had any public health benefit or, if they should be on the market. So after this amendment, no product can come to market after August of 2016 without a pre-market review authorized by the FDA. Now, obviously, we still have e-cigarettes on the market. So in a couple of slides, I'm going to talk about why that is and what we're going to see changing. So why do we have these new regulations? Why did we have that 2016 amendment? Again, something that we all know and that we're familiar with. We've seen this rate of smoking in adults, but really what I'm focusing on in this slide, in young adults in particular, reach its all-time low in recorded history. So that's great. We have less people smoking, but, slide, we have lots of adults and particularly younger users using e-cigarettes. So the bar graphs on the left look at e-cigarette use among middle and high school students. And again, this is a little bit dated, but you can see that in not too dated, but 2019, almost 30% of high school students using e-cigarettes and 10% of middle schoolers. If you even look before that, we've seen such a big spike in this e-cigarette use between 2011 and 2015. We saw over 900% increase in e-cigarette use among high school students. So this is something, again, that's just continuing to grow. If you look on the right-hand side, we have lower percentages of adults using e-cigarettes. But if you look, again, at those bar graphs, the highest prevalence are going to be in that young adult age range, the 18 to 24. So again, I'm not saying that these people weren't former smokers, but really it leads us to believe these are probably people that were we're going to see some changes with these new guidelines. So after this 2016 amendment, now we're saying that manufacturers of e-cigarettes do need to submit to the FDA to make sure that their product meets applicable public health standards. But they can continue selling their products while they submit their FDA application. Now, when that amendment, that 2016 amendment first came out, there was no timeline on it. It basically just said, if you weren't on the market prior to 2007, you need to submit to the FDA. This past July, a federal judge did put a 10-month deadline on these e-cigarette manufacturers to apply to the FDA. So by May 12th of 2020, they have to submit their product to the FDA. If they do not, the FDA then has the authority to remove it from the market. However, once their packet is submitted to the FDA, it's going to take some time to review this, approximately a year, and they can continue to sell and market their products while it's under review. So let's check on how things have been doing since all these regulations have gone into place. What has really happened? Slide. So we have retailer and manufacturer checks being conducted. These are under the FDA, and they basically have done inspections of manufacturing facilities as well as those selling the e-cigarettes. So an example here, they did 1,200 vape shop inspections, and these inspections included both like brick and mortar type stores as well as online retailers. And they found one company to be illegally marketing e-liquids. Go ahead and slide. And something else that the FDA is really trying to do is put in place what they call a youth tobacco prevention plan. So go ahead and slide. Oh, I think I missed a slide here, but that's okay. So we're going to talk about why the youth tobacco prevention plan is important, but as I mentioned, these are some of the flavors of these e-juices on the market. Who do you think they're marketing towards? Is this marketing towards an adult smoker trying to quit, or are we marketing towards kids? You can see the flavor there is unicorn cakes. Looks very similar to, I can tell you, my kids told me that is Princess Celestial from My Little Pony. So if you care to know that, this slide. We have, an e-liquid chill that's purple grape. Looks very similar to a purple Fanta grape. That slide. And then the cereal Frankenberry, and then we have Franken Vape. Go ahead, slide. So again, looking at these things that are on the market and who they're really being marketed towards, the FDA has put in place this youth prevention plan. And they have 3 areas that they're trying to target. 1 is preventing youth access to these products. 2 is inhibiting the marketing that's aimed at youth. And then 3 is providing education. So you may have seen some commercials on TV. In 2018, the FDA really expanded their youth prevention plan with a campaign that was called The Real Cost. And it targeted ages 12 to 17. And again, I've seen some commercials on TV, but there's a lot of advertisements with it in social media as well. So I mentioned that the FDA is doing inspections, and they do these compliance checks with regards to sales to youth. So basically, again, both online and brick and mortar, they are not allowed to sell, or they need to card anyone who looks to be under the age of 27. And I know that graphic is a little small, but basically it follows the chart of what happens if that retailer is found to be in violation. So you can see it starts with like a warning letter, then they get some fines, and it kind of grows from there. And you can see between August of 2016, September 2019, they sent over 8,000 warning letters. Now, I'll be honest, if you read this from the FDA or the CDC website, they're very proud of these checks and this prevention program. And I do think it's great that they, are trying to monitor this. But I don't know, in my opinion, it doesn't seem like that many warning letters. And what weight does that fine call? How much of weight does that carry? Like, if they're doing these huge sales of these products, is a $292 fine really going to hurt them that much? So I don't know. This is what's out there, just sort of, an opinion you may have on that. Go ahead and slide. So I keep referring to changes in regulations with regards to the flavorings, and this went into effect January of this year. So I wanted to look more in depth with that. Slide. All right, so fun question here. According to research, which of the following is the most popular e-cigarette flavor among high school students? Do you think it's cherry, mango, mint, gummy bear, cotton candy, s'mores, or honey? So I didn't include like Frankenberry or grape or any of these. All right, so for time's sake, I will close the poll. I was gonna say no one got it right, but someone just did. The correct answer is actually C, mint. Can you believe that? I think that's very surprising. So high schoolers prefer mint flavored e-cigarettes. And then if you cared, second is actually mango. And then third was fruit flavored. Okay, go ahead and slide. So a lot of information on here, but let's look at the timeline of these flavor bans. So back in September of 2019, President Trump announced that he would take strong action against the teen vaping epidemic by banning the sale of most flavored e-cigarettes. So do you think that e-cigarette companies were happy about that announcement? Absolutely not. So they really mobilized and sort of attacked this. So they, groups that represented vape shops from across the country created a campaign that's called We Vape, We Vote. And they had a whole media campaign. They did posters and they ran television ads, which was really interesting, that were targeted in Palm Beach, Florida, where President Trump was vacationing at the time. So they were given a lot of pushback against this initial announcement. What's interesting is the next month, Juul, which again is our largest share of the market with these e-cigs, announced that they would voluntarily suspend sales of most of their flavored products. We'll look more into Juul in a second. In January of 2020, we had this partial flavor ban announced, and it forbids the sale of most flavored e-cigarette cartridges, but there were exemptions to this rule. The exemptions were that they would continue to sell menthol and nicotine flavors and flavored nicotine sold in open tank systems at vape shops. So why is this important to know? So that last question I just asked you, what flavor do most high schoolers prefer? And the answer was mint. Well, now we're banning mint flavors. The American Medical Association has put out a statement that they're very concerned now that these students will start using menthol flavored and again, be a gateway to traditional cigarette smoking. The other thing is you can see that we are not banning the open tank systems. So that means that people can still go to a vape shop and get any flavor nicotine in those.
Left for the second.
Okay.
Thank you.
Perfect. Yep, I'll end. Wrap up. So this is a settlement that Juul reached with the Center for Environmental Health. There's a lot on the slide. I'll let you read on your own for time purposes. But basically, this is really sort of a groundbreaking sort of thing because it was the first time that there was a legally binding settlement with Juul. And it put a lot of restrictions with how they can market and sell their products. So you can advance 2 slides if you want. 3 slides, keep going. So another thing that I think is important to note, there is currently no cap on the amount of nicotine that can be in these ENDS products. There was a bill that was proposed that would put a 20 milligram per ml max. It has not gone anywhere. So again, at this time, there is no max concentration. So some brands contain very high amounts, much higher than that. So you can see a 5% Juul pod contains about 59 milligrams per ml of nicotine. And as we know from a traditional cigarette, the user's taking in about 1 to 2 milligrams of nicotine. So again, much higher nicotine concentration in these products. Go ahead, slide. And I wanted to point out that many states have tried state-specific bans, the first being Michigan and Rhode Island as well. As you can see, has state-specific bans, but many, actually all of these has been overturned. And right now we really only have the federal ban in terms of that partial flavoring. Okay, so go ahead and slide. So what can we do as healthcare professionals? Slide. Unfortunately, we don't have guidelines. The last guidelines from the U.S. Department of Health and Human Services were from 2008. And so that was when e-cigarettes are new and they really don't address those. Slide. So what we can do, if you want to go ahead and click so the answers to these show up, is we can follow the brief and intensive interventions that are in our guidelines. So the brief interventions, ask a patient if they use tobacco, advise them to quit and refer them to help, or doing the more intensive interventions, asking, advising, and then assessing their willingness to quit, assisting with that quit attempt and arranging follow-up. We can apply these same things to e-cigarettes, but I really wanted to emphasize making sure that you include e-cigarettes in that ask. So when you're doing an intake with a patient or you're asking them, make sure you include e-cigarettes because many don't think of that as smoking. Go ahead, slide. And then lastly, we do have a lot of major retailers discontinuing sales of vaping products, which is great. Slide. And lastly, I wanted to give you some resources available to help patients quit. Honestly, these are just some examples. There are so many more, but these are some of the ones that I tend to use, especially that first one. Really, if you go to any website now or any app that is a smoking cessation app, they tend to have a section on e-cigarettes as well. I really like Become an X because it does have this website where you can track your e-cigarette use and look at your triggers for e-cigarette. But again, just some references that you may be able to implement with your patients. Okay, slide. So just in summary, these are not FDA-approved devices. Hopefully, I've made the case that they are not safe. And we talked about, in particular, the vitamin E acetate causing that EVALI and a lot of the changes in our regulations. So with that, if I have time, I'll answer any questions, or please feel free to contact me afterwards as well.
Certainly. And thank you so much, Jamie. That was, I really enjoyed that talk. So much valuable information. I know, vaping is such a hot topic and such a concern. And, really, I have to say, I was shocked when I saw the dollar amounts that are attached to those fines. It's just, there needs to be a greater focus on that. As you mentioned, I think the highest one was something like $11,000 or $12,000 in comparison to what these companies are making in sales. That's barely a drop in the bucket. So I think greater, even more attention and, individuals such as yourself really helping to educate us and inform, healthcare professionals, and how do we help to support individuals to first not even start vaping, but to provide some counseling to stop if they have started. So I will see if any questions have come in. Do I flip to the next?
Yeah, so I was going to say my contact info is there as well if anyone has any questions afterwards.
So I will, I'll ask this question out loud. What would stop users from including illicit substances like cocaine?
So I'm not sure if the question is asking the user or the manufacturer. At this point, I mean, we talked about the regulations. They're hopefully, as of May of this year, really things on the market are going to be regulated in terms of e-cigarettes and what is in those products. But, it's like with any type of illicit drug use, you can't stop everything. So, I don't know if there is really an answer to that one. The question says, what's the answer to the case study? So that was an open-ended case study. There's not one answer. Hopefully I was helping you to form an opinion through the talk. So as I mentioned, what I usually tell my patients is that, yes, these products are safer than cigarettes, puff for puff, but that doesn't mean that they're safe. So if I teach group smoking cessation classes, and I've had patients come to my class now that use e-cigarettes that want to get off the e-cigarettes. So, there isn't recommendations out there in terms of pharmacotherapy yet as to what we can use. It's a lot of trial and error. And that really ties into because we don't know the amount of nicotine they're taking in from that e-cigarette. So I do a big role in trying to prevent people from starting to use these. But if they are using an e-cigarette, then I really try to work with them, whether it's just counseling or whether it's also pharmacotherapy to get off of the e-cigarettes. Do you want me to go through all of these questions, or how are we on time?
Oh, great. We'll document those, and we'll send them out to you and get the responses back, and then we'll distribute them to attendees.
Okay, perfect. Okay. Thank you.
Excellent. Well, thank you again, Jamie. That was really fantastic.
Thank you.
Okay, so moving along. So for our next session, advancing workforce well-being and resilience to building long-term change. It is my pleasure to introduce Dr. Ann Policastri. Ann Policastri is a graduate of the University of Kentucky College of Pharmacy, and she also received her MBA from Murray State University. Dr. Policastri has extensive experience in health system pharmacy, from staff pharmacist to vice president for professional and support services. Education of the next generation of pharmacists is a passion of hers, having been a preceptor for many years and also a former full-time faculty member at the University of Kentucky College of Pharmacy. She has served in a variety of capacities for state and national pharmacy associations, most recently as executive vice president for the Kentucky Society of Health System Pharmacists. Currently, Dr. Policastri is the Director for Affiliate Relations at ASHP. Please join me in welcoming Dr. Ian Policastri.
Thank you.
There's a clicker there if you want to use that as well.
Okay. No, you can edit. I'll get started here. So, wow, what a big room, and it's nice to see that everybody is practicing their social distancing from each other. She's going to make a quick edit in my slides because she's got something fun in there that I didn't know how to do, and so I'm always willing to accept help when I can. So I realize I'm the only thing standing between you and lunch, so we will try to make this fun. I'm going to put up a list of objectives in a few minutes, and those are the things that MJ made me put together so you all could get continuing education credit for this. But when you leave today, I want to give you a couple of personal objectives of mine to work on as we're going through these slides. And one of the things that I want you to do, we're going to talk about well-being and resilience. And as we go through, you'll see that there's a couple of different ways that you can look at it. There's your own personal internal skills for well-being and resilience, and then there's also those external that are probably more from your workplace. So I want you to have a couple of your own objectives, and one of those is I want you to come away from this talk with one thing that you're going to do personally and individually to increase your own well-being and resilience. And then second of all, we're going to talk about the external environment, and perhaps you can come away with something that you can do at your workplace that's going to improve well-being and resilience for everyone you work with, your staff. So it looks like we're ready to go here. So I told them that I like to walk around. Being a former faculty member, I always got out in the class because that way I could see who was really sleeping and who was Facebooking and what they were doing. So it's kind of hard for me to stay on this stage, but I'll try to kind of go from side to side so I can at least see who's here and if you all are still awake or not. So let's get started. I don't have anything to disclose other than saying that this is just a personal thing of mine that I think is something that we all should do. These are the learning objectives that MJ made me put together, and as you can see, they're very technical, but what I want you to do is go away with one idea that you're going to implement for yourself, and then an idea that you're going to implement in your workplace. So let's do a definition here and talk about what well-being really is, what resilience is. So this is a word cloud. So what I'd like you all to do is just to put some one-word definitions down of when you hear well-being, what comes to your mind? And let's see what we get. Oh, you have no idea. I'm working with meetings all across the country that are being canceled. I would like it to be COVID-free. These are always really fun. So balance, happy, content. We seem to find some winners here. So as we go through this, let's see if your own personal definition actually matches what the experts say. All right. Are we ready? Ready to move on? Okay, thanks for participating. So every time you pick up either a journal, the newspaper, a periodical, you hear something on TV, it seems like if it's not the COVID-19, it's about well-being and resilience in the workplace. And I think it's something that's getting a lot of press. And certainly those of us that go through stressful times as far as what we're doing right now with having this new virus out there, that I think it is something that imparts a lot of stress on us. And it really affects our work and how we treat others. So let's see what the experts say on well-being and resilience. So you all got some of them. It's the presence of positive moods. And I think that is true. It's the absence of negative emotions. And it also is satisfaction with life, fulfillment, positive functioning, and physical well-being. So for me, that's a very holistic approach when you're looking at things. I think some people say, oh, I do yoga, I'm working on well-being. Well, that's one part, and if that is meaningful for you, then I think that's a good thing. But it may not be. You may get just as much joy and pleasure from being with your family and friends, and that may be a stress reliever for you. For me, as you can see, most of my work has been in Kentucky, and I actually live there. I'm a remote worker for ASHP, and one of the things that de-stresses me, so I live on a 2-lane country road, and I go between horse farms. And at this time of the year, with all of the new little foals out there and they're frolicking around, who can be in a bad mood? That soothes my soul. Another thing that I like to do, and some of you all may like to get out to walk, run, those type of things. That's my favorite thing to do in the morning, is to get out when it's a sunny day, it's pretty, 6 a.m., I've just gotten out of bed, and just to go out there. I don't use earbuds. I'm not listening to podcasts. I am present in the moment, and I am enjoying nature and just being outside in the movement. So I think whatever it means to you, whatever you find in yourself that kind of centers you and makes you feel calm and relaxed, that's a good thing. I take yoga classes periodically, and I started one a couple of weeks ago. And the instructor, it was really funny. She said, you know, if you're here because you think it's physical fitness, you need to leave. What we are doing is using yoga to still our mind. And so we use those poses, and that's what's going to help us get to the place where we need to be mentally. So I thought that was a really interesting way to look at it. So I encourage everyone to explore those things that help calm you and make you feel complete. Other folks, when I've given this, they felt like that maybe we missed an item here. And, you know, I think satisfaction with life, fulfillment, and positive functioning covers a lot. But they really felt like for some folks the spiritual component needed to be in there. And so I think if that is something that is meaningful for you, certainly it does belong. So as we're looking at resilience, what resilience really does, it's that set of skills, those coping mechanisms that we have that help us deal with those day-to-day stresses. Because guess what? We're in healthcare. We're always going to have day-to-day stresses. Hopefully, we can get through those and do our best to help our patients and others. But we're never going to be free of being in an unstressful situation. You know, you're working with people when they're not their best. And I've worked in a variety of settings. I'll say most of my time has been in health systems or in the hospital, but I've also spent my time in the community environment as well. And when you think about it, a lot of times they may be angry, you're just the messenger, but you still get the brunt of it. And I think you've got to remember these folks, for the most part, a lot of them are are not feeling at their best. And so think about how you feel when you're not at your best. You probably have a little bit of a short fuse too. So, you know, sometimes it's just kind of removing yourself from that situation, trying to put a little more understanding there. But I do think that it is important for us as healthcare professionals to be able to take care of ourselves and to give and do our best. So hopefully today we'll go over some studies, we'll look at some different things, and then we'll look at some ways that we can improve our own well-being. So when we get to the term burnout, there actually is a true definition for burnout. And it's defined, it's a syndrome of depersonalization. And a lot of people say, well, what is that? And it's really, instead of thinking, I'm going to talk with my patient, Mrs. Jones, about her anticoagulation, suddenly they're just a disease state, or maybe a less than flattering name. It's just like you have taken away that individual person. And so when you get to that point that you can't care about your patients individually and as true people, that's not good. Another trait of this is emotional exhaustion. And that's to the point of you go home and you just can't take anymore. You can't deal with anything else. And it's more than just being in a bad mood. It's just like, you know, you're at the end of your rope. Another thing, the third part of this syndrome that's called burnout is low personal accomplishment. And I think as pharmacists, a lot of us are really type A behavior, and we probably want to always do our best to excel. And sometimes at the end of the day, if you can't find anything good of what you've done during that day, you do walk away with that low sense of personal accomplishment. And so to say someone is truly burned out, it's a syndrome with all three of those. You know, and I don't want to say that stress is all bad. We all need just a little bit of stress in our lives. You can see here this graph, because this is a pharmacy CE, and we've got to have a graph of some type, right? So looking at this, we've got performance and stress. And actually, if we have no stress whatsoever, we're probably down at the lower end where it's actually boredom. It's been a while, but I can remember working at times when, gosh, you're wondering if somebody's got a deck of cards because you don't know what you're going to do. I've even worked at some really small hospitals doing relief, and I mean, I have read the paper on a Sunday morning from cover to cover, even things that I really didn't care about reading. I just wanted to have something to do. And I'll tell you, I was not engaged, so if something came my way, you know, it would take me a while to kind of gear up and engage all of the brain and get it moving on all cylinders there so I could make good decisions. So I think we want to have enough stress in our lives that we're focused, we're on point, and that we are our best. Now, once you get a little bit too much stress, you start getting a little anxious. I don't know how many of you, maybe you have had a busy day, and you go home and it's like you can't remember the complete process. Did I do this? Did I get this checked right? Did I get this sent out? Oh, what bin did I put that in? And that's not a good place either, where you're just anxious. And then, of course, the other end is burnout. And so we want to stay in that happy medium. One of the things that I did when I was a director of pharmacy is I looked at all the medication errors that were made. And I looked at it for our pharmacy staff. And one of the things that I would do is I would look to see what time of day it was when the errors were made. I would look to see how many orders that we were processing at that time, because I wanted to get a feel for how busy, how stressed they were, if there were any things that were that I could do. Maybe I hadn't staffed right, maybe we needed to change some processes. So where do you all think we were at on this graph up here where I saw the most errors? To the burnout. Yes, there were errors there, but guess what? There were just as many errors made when we were probably at the boredom. Because as I said earlier, you're not fully engaged, you're not aware, you're not ready to take care of what's coming your way. So that's why I say there's that sweet spot in the middle that you want to be engaged enough with what you're doing that you get there. So the whole point of this slide is there is that place of eustress where things are good and you need just a little bit of stress in your life. You know, everything we do is a balance, and so as we look at those different stressors that we have, some things are good, some things are bad. You know, it's constant that what you have to do is try to keep all of that in balance. And you know, despite what they say, you can have and you can do it all. Well, you probably can, but not all at the same time. So I think every day you have got to make decisions in your life as far as what's important to you and where you want to put your attentions, because it is a very delicate balance to stay into. Oh, whoops. I guess I have polling questions. All right. I was lulled into that sense of what's going on here. So, are we ready? So you all can answer this. It looks like we've got one person that has answered. So what do we think about burnout is? And remember, I gave you 3 things that had to be present. Oh, you all are thinking. I'm with you with that needing a beverage at the end of the day, but a lot of times that's just fun. Okay, so emotional exhaustion, yeah. So think about that syndrome that we had with the three elements, the depersonalization, and the emotional exhaustion was the second one that was there. So, so you all are paying attention. So it actually is a true workforce problem. So in May of 2019, the World Health Organization, when they have their international classification of diseases, they came out with number 11, the ICD-11. And so when they looked at that, that's the first time that we did see the burnout syndrome in the workplace is actually being a true classification. And that's going to start in January of 2022. So I think, you know, it kind of adds a little legitimacy to it. It's not just that we're burned out, we're stressed, that it really is an issue. When we did this as a workshop on Wednesday, somebody had a great point is, you know, how do you know that it's just confined to the workplace stress? And I would hope that the healthcare professional that was working with that person and when they were classifying it, that they would fully explore what else may be going on in that person's life. But I do feel like that certainly there is a workplace component. So about 10 years ago, when they were really trying to say what we needed to do to fix the healthcare system, the IHI came out with a triple aim and said these are the things that we need to do to make our health care better. And I think a lot of that, they were looking at access, they were looking at costs of care. Well, recently they came and said, you know, instead of just a triple aim, we need a quadruple aim. And what that is going to do is to bring that care team well-being in there, knowing that if we're all not functioning to our best and we're not working together, that we're probably not doing the best that we can for our patients. So looking at why do we care about if you're burned out or not? Well, it has to do a lot with patient safety. And what this was is this was a large review, 46 studies, and it really was looking at the relationship between burnout and medical error. And it found that there was a strong correlation there. And so when you think about it, if I've made a medical error, that's probably making me feel burned out because suddenly, It's just like I'm doubting myself. I'm probably ordering more tests. I'm asking for more opinions. I'm stressing, is this right? Is it not right? So, you know, you've got those issues. If I'm really burned out, and when you think back to that syndrome, I'm probably going to make more errors because I'm not focused, I'm not at the top of my game, I'm not doing what I need to do for myself. So looking at it that way, it almost gets in a vicious cycle that if somebody's had a medical error, it's probably leading towards burnout. In the same way, if you're so stressed that you're heading towards burnout, then you probably are going to make more medical errors. So even looking at patients themselves, and they looked at over 2,000 American patients and found that 8 out of 10 were really concerned about their healthcare providers being burned out. And I think even our patients are seeing that when we're not at our best, when we don't have time for them, that they're not getting the best care that they can. So I mean, it is a big deal. Looking at some studies here, now this study for me, it had a low response rate, only 12%, so you really are only looking at probably about a little over 100 folks on this. And I suspect that probably those that actually replied were more on the burned out side, and they just wanted recognition for that, because I do think these numbers are a little bit high. But what I do like about it, even though I'm not sure I trust the numbers, but when they look at those predictors of burnout, I think those are very accurate. So I think, you know, as pharmacists, we want to be pharmacists. And when we get to the point that there's too many non-clinical duties that we have to put out and we have to do in our day, that's a stressor, because that's not what we love to do. That's not why we went into this profession. So for me, I look at, you know, what can your technicians do? What can your interns do? What can you hand off to allow yourself to do more of those things that need your particular expertise? Another thing, when folks have inadequate teaching time, and since you're preceptors, I think, you know, when you don't have time to spend with your students, you feel guilty. You know, that's a stressor in itself because you want to do your best. Folks that have to do schedules or other administrative tasks and they don't have the time to do that, that's a stressor because it's kind of that role conflict. And then I think we've all worked with those difficult pharmacist colleagues. Yeah. I don't know what you can do with those. I mean, I think there's always going to be folks there. But another thing that I think we can do something about in the workplace is contributions being unappreciated. So how many times do you all just say thank you to those you work with? Yeah? And that's important. You know, and it's not just a blanket thank you or, wow, y'all worked hard today. I mean, it's really talking to somebody on a one-to-one basis and thanking them for something they did that went over and above. So I know I used to always keep some just thank you cards on my desk. And, you know, just the value of writing something out and giving it to somebody. You know, you could see when they would go by their mailboxes and get their little thank you card out, it kind of brought a smile to them. You know, so that's kind of another low cost, almost no cost thing to do, is just take a few moments and thank somebody, write it down. You know, we see so little in the snail mail anymore. For me, I also used to have some $5 Starbucks cards. I think here Dunkin' Donuts maybe is a little more prevalent. So just those small things, and you know, just to buy somebody a cup of coffee. I always said, you know, that latte sure tasted sweeter when somebody else was buying it for you. So I think there are little things you can do in your workplace to have others feel appreciated, but really, I don't know about you, but when somebody thanks me, it makes me feel good. And I think some of those little feel-goods throughout the day really go a long way. So this is another study that was done. This actually was done at Duke Hospital. And one of the authors on this is Paul Bush. And Paul Bush is a former president for ASHP, and in fact, he was the one that got us into this initiative with the well-being and resilience that's really become a cornerstone of what we do. And the reason I like this is I think it's reasonable. They had over 300, so it was a little bit bigger survey. And when you look at the numbers, those three things, the emotional exhaustion, the depersonalization, the low sense of accomplishment, you know, I think those are probably pretty realistic as we look at our colleagues and what we've seen. So I do think this study is worthwhile. One of the things here is they even broke it down as far as to what specialty people were in and where they worked. And I think you can see the black bar are the burnout, the folks that were experiencing that, and then the green bar, the non-burnout. And you can see there are some areas that I think are very fast-paced, that are very stressful. And you can see that. You know, the general medicine, I think those are large services, a lot of patients, a lot of variety in what you see. You really have to be on the top of your game there. Looking at intensive care, of course, anybody that is, you know, in those critical situations, that's stressful as well. Emergency medicine, you know, but then you look at some of the others that it's a little more even. So I tell everybody to, when I used to work with my students, look at your personality. What's a good fit for you? If you can handle that fast pace coming at you all the time, top of your game, really high stress environment, go into the ICU. Do critical care. But somebody that maybe that's not their personality, maybe they need to look at things that are a better fit for them. So with residents, and I know, does anybody here have residents at their place of business? At their few residents. So one of the things with residents, and I know that's a stressful time, it's like you're trying to pack in, you know, in 1 year, 5 years worth of knowledge to them, and you don't want them to miss a thing. Well, once you get over a certain number of hours, they start stressing out too. And you can say, oh yeah, they're young, they can handle it. Well, not unless we help them with coping mechanisms to be able to do that. So, you know, whether you're working with students, working with residents, I think those of us that are more seasoned, that have been doing it for a while, we need to kind of take them under our wing, especially when you've gone through a stressful period, and, you know, let them know it's okay to feel overwhelmed. You know, it's not a personal deficit for them, that we're all feeling like that. And if you can give them some little tricks and tips and things that'll help them feel better, you know, I think those are some of the most valuable lessons we can impart. This study here I really liked. I just kind of blew up one of the tables that was in the article because I like fixing things. And so I think if you know what those risk factors are, then it's much easier to start saying, how are we going to fix things? You know, when we start looking at the workload, and if you're in a position, is there something that you can do maybe to move things around or have people at different times of the day so that workload maybe isn't quite so great? When I look at control, you know, if you give people things to do, give them the authority to take care of it. Let them know what they can do, what they can't do. I think that's important. We've talked a little bit about reward, and when I say reward, it can be financial, it can be personal thank yous, it could be days off, whatever it is. Could be recognition. I don't know if anybody has where they can get an award, Pharmacist of the Year, or if you have an Employee of the Week, or what month, whatever it is, that they can be rewarded for their efforts, if that works. I think community is another thing that we all need to kind of form community within what we're doing. And when I say community, it's a collection of people where it's a safe space where you feel like you can let others know how you really feel. And you can help each other. And those maybe that have been through something before can say, this is how I got through it. This is what made me feel better. So Oh, I'm already getting a 5-minute warning? Oh, okay. Woo. Oh, okay. I thought, wow, I hadn't told that many stories yet. I've been trying to hold it back. Another thing that I think we look at is we certainly want to be fair with everybody we work with. And I think one of the things personally for you or for anyone you're working with, your values really need to match that of your organization. And if you don't, I think that's going to be a constant issue. And if you don't feel like you have the same values as your organization does, then maybe that's time for you to look at an organization that does share your values. And then another thing, just kind of looking is, does your personality kind of match what you're asked to do? I've had a lot of people come up to me and say, gosh, I can't believe you can go talk in front of people and you don't get nervous at all. And I said, oh, years of practice that. And, you know, the lowest point I ever had, I was a program chairman, and I don't know why I thought we needed to rent this riverboat and have karaoke. And I should have realized that pharmacists don't do anything fun until the lights are low and they've had a couple of drinks. So anyway, long story short, I can't carry a tune in the bucket, and I got up there and karaoke'd. I knew that was the lowest point I would ever have in my entire life. Everybody certainly felt like they could get up there and sing after I did. I'll give it that. But at that point in time, I knew that anything else was on the way up. So it really does not bother me. But I just need to look at those things. So there's a few more studies up here just to show you that work's been done not only in residents and pharmacists, but there's also technician work out there as well. So whoever you're feeling might need help, there's a study out there for it. Okay, another question up here. So this by Dr. Jones, the one that I really didn't like because it was a low turnout, only 12%, and I'm trying to lead you down the path. So we're looking at here, we're kind of split 50-50. So it's not a strong predictor, not a strong, capital not. Because I think most of you are getting it now. It's C. Lack of advanced training and certifications. You know, that doesn't protect burnout. You know, a lot of the people that are burned out are very highly trained, and they're certainly very accomplished and capable with what they're doing. So once again, that just kind of plays into that it's the situational. So moving along, oh, there it is again. So talking about burnout, I want to get a little audience participation here to make sure that you're with me here. Have you seen burnout impact patient care? Does anybody want to volunteer how you've seen it work? Can they write this in, or you can go to the mic? Do we have a mic? Oh, we've got a standing mic in the middle. So we've got a yes. Worse outcomes, got that. Lack of empathy when burned out. That is so true. And I think that's probably one of the most valuable things that we can give our patients is to empathize, and because a lot of them are going through things, and I think that helps them get through what they need to. So yeah. So I think we're all in agreement that as you go towards that burnout phase, that you cannot be your best. So. All right, we're kind of getting repetitive, but I'm glad everybody's feeling that way. So we're all on the same page here. I'm going to move on so I don't get that 5-minute warning again. So the National Academy of Medicine, let me just talk a little bit about that. In January of 2017, they decided this was a real problem for healthcare. And so you can kind of look at that timeline across the top. This is a 4-year project of theirs. So ASHP, we jumped in probably about 6 months in, and we became one of their founding members and working with them. And we've kind of been tracking what we're doing right along with it, whether it's changes in our meetings, things that we're doing in terms of providing education, making it a priority of ours, going out and talking about it. We had a great time in our workshop on Wednesday looking at well-being and resilience and what we can do. And so we're trying to do more of that and just really bringing awareness to the situation. I don't know if anybody read To Err is Human. It was a publication by the National Academy of Medicine. They've come out with a paper that's really pretty good and worth the time to read it. To care is human. And I think sometimes we can learn from others, and this was a paper written by physicians, but I think it's very true in pharmacy as well. So definitely, it's not that long, but it's really worth a read. Another thing, looking at the National Academy of Medicine, their Action Collaborative, one of the reasons, just looking at what their goals are and looking what, for my employer, ASHP, what we believe our goals are, and you can see they match up pretty well here in terms of what we want to do to have a healthy, resilient workforce. It's actually part of our strategic plan. And what we do, talks like this, go into our metrics and things that we're doing to let people know that what they can do to improve their well-being and resilience. And then here's just some of what we're doing, certainly participating with the National Academy of Medicine, doing education such as this, and really just looking at opportunities, especially with those in residency training, but also with students as well, and then looking at continuing to provide research to help us know how to help others. We, in 2018, our House of Delegates put forth a policy, so we really feel strongly, and it pretty much just says we know it's a real thing, and we want to do what we can to help our pharmacists, our technicians, our students, residents, to learn how to handle those stressors of every day. And then a couple of more papers. These are all linked in. There's references, citations there if you want some reading. Most of the things are available for free on the National Academy of Medicine's website. And then look at strategies. This is my favorite part. So I think you all either got a copy of this or this handout was linked in. This is what the National Academy of Medicine came up as their conceptual model. And I think it's important because you look at it and it's like we put our patient at the center of it. Then there's those relationships we have with our care team, but also we have to bring in our own well-being and into the puzzle. But if you look on the outside, everything that's yellow, those are external factors. But the blue are our own personal individual factors. And this diagram, if you don't have it, it is on the National Academy of Medicine's website. And it even breaks down each of those sections that are on the outside of that ring into, gives you a list of different things that you can do and that you need to look for. Great document. So let's look at those external factors first. And I think one of the things is saying that we're working within a team. And this is off of the National Academy of Medicine's website. And it really talks about putting it together as a team care. They're looking at it a little bit more from the interprofessional team. But I certainly think within our pharmacies we have a team. With our technicians, our students, anyone that we may be working with, that we need to make sure that the team works well, that we support each other, that we trust each other. And some of the key things here, everybody has got clear roles on the team. They know what they're supposed to do. There's a lot of studies out there showing that you do get better results when you work in that team, because I think we all approach problems, patient care just a little bit differently, and when we work together, it is the best for the patient. It also relieves some of the burden, If I know that somebody else has my back and I have theirs, I think that gives me a little bit more of that well-being, that it's not all just me, somebody's going to help me out along the way. This is another thing from the American Medical Association that I really think it's good, and this is what they do with their residents and their fellows, and how to have that infrastructure to make a wellness culture work. But this really could be adapted in any situation to a workplace or whatever, that it kind of gives you that framework of what you need to do to confront the burnout, to work better together, and to create that culture. National Academy of Medicine, they had To Err is Human. Many of you may have read that. Then a little while later, they came out with Crossing the Quality Chasm, another good read. So the latest one that they have come out with is taking a look at the clinician burnout. And you can download it for free off of the National Academy of Medicine's website. If you buy it as a paperback, I think it's about $70. So, but you can download it for free, and I have read portions of it. I'm not going to say all of it, but I've read portions of it, and it's very well done. I know my organization, I think APHA, AACP, a lot of the organizations have devoted space on their website where you can go and get help and see what you can do. I know ASHP, we have some nice infographics that are handy to have that kind of gets it out there in a very visual way. Looking at individual factors here, some of the ways you can identify burnout, there's actually this MASLAC burnout inventory that was created especially for healthcare professionals. And I think there's a cost with that. I don't think it's a high cost, but that really lets you see where you are on the spectrum. This is on the National Academy of Medicine's website, and they have some other tools on there that you might find that would work better for you, your staff, those you work with. But certainly, we all need to know where we are kind of on that spectrum. And then individually, we can work on our own skills. Need to monitor your stress level. I know sometimes during the day when things are coming in and so much is coming at me, sometimes I just have to get up and walk around or take that Starbucks break just to mentally get away. And I know when I reach that point that, you feel like I can't get up, I can't get away, I can't do anything else, I got to get this done. But sometimes if you can just take that brief step away, and even if it's only in your mind, just for a minute or two, stand up, go get a drink of water. It's amazing how just giving yourself it's okay to take a little break when you need it. And so the more you get to be able to monitor your own personal stress, you know when you need that. I'm big on finding a mentor. There are a lot of people that have been through what I've been through before me, and it's rewarding to me when they tell me, yeah, I felt like that too, and this is what I did. And so I think that is helpful. So if you see a colleague, if you see a student, if you see someone that you feel like that you can give information to, just take a few minutes, take them aside, let them know it's okay. Tell them how you got through a similar stressful event. Meaningful social connections is good. And make sure that, that you do have that trusted circle of friends. And I say face-to-face friends. It's easy. I know a lot of people will get on Facebook and vent, or maybe on Twitter or some other social media. But I really think if you can find somebody face-to-face, we really need that human connection there. And then another thing, embrace change. It's going to happen. A lot of people don't like change. It is hard to deal with, but equip yourself to be able to work through and manage that change. One of the things that I think is really easy to do for yourself is a daily gratitude practice. And it can be as simple as getting a little notebook, just a lined legal pad. I know there's some pretty ones out there that you can order or get at a bookstore. Some people like to use electronic apps. But at the end of the day, if you just think of good things that happened to you, things that you're grateful for, you know, I've done that, and I'll tell you, as you go through that next day, you start looking for things. Wonder what I can put down, and you start looking for the good things that happen to you and the good things in life, and it does. It makes you feel better. There's evidence out there, there's studies out there that just those little simple things. So usually at my talks on this, somebody either is shopping on Amazon, getting one, maybe they're downloading an app. There's a lot of journaling apps out there, a lot of them free. So just try it. You know, talk about low cost, low commitment. You don't even have to tell anybody. Just do it for a week, see if it makes you feel better. And then realizing when I put this as one of my favorite activities and where I am, and I'm thinking, wow, that's going to be on the big screen, and they're going to see that sale's probably not trimmed as much as it should be. So I'm thinking that, you know, I like to be outside. This actually is from Kentucky. In western Kentucky, we have Kentucky Lake. It's 53 miles long, and it's about 5 miles wide at its widest point. So anyway, find an activity, find that happy place for you. I know for me, so I've got this great room here at Gurney's. I mean, I love it. It's so I've got my windows open. I'm up on the 8th floor, and every morning since I've been here, I wake up and all I see is water, and it's beautiful out there. So I'll say I found my happy place, and so whatever speaks to your soul, that's what I was tweeting out to folks. And I'm like, look at this view. It soothes my soul. So find something that makes you happy. And then looking at stress, here's some good self-care things. We talked about monitoring our own personal stress. What are those healthy things that you like to do, whether it's a deep breath? I know my watch tells me to breathe. You know, if that helps you to have those reminders, do that. We talked about the gratitude journals and maintaining those social connections with folks. Very important. This came from the Mayo Clinic in terms of promoting well-being. I think as you look through here, we've talked about all of these things in terms of what you can do. I think it's good to promote flexibility, that work-life integration. Those that you work with, if people can do a little job sharing or help each other out, encourage that. Let me see if I got time for a quick story. One of the things that really worked well for my staff is, so I always had at least 2 pharmacists working in kind of a medium-sized, small, medium hospital. And on Sunday morning, they came to me and they said, you know, it's pretty slow on a Sunday morning. We know we could be getting other things done, but it'd be important for us. Would it be possible for us to trade off and have one be able to go to church services and one attend their Sunday school services? We'd still always have one pharmacist here. We'd never leave it. And I'm like, oh, thank goodness, because we'd be illegal. But anyway, so we instituted that on Sunday morning, and we even let some of the technicians start doing that, as long as we've had what we felt like was an adequate complement there. And you would be surprised how suddenly working weekends wasn't quite so bad. And you know, I was letting them do something that was very important to them. And as we're looking at this whole realm and adding in that spiritual component, that I think that little bit of flexibility really made a difference for them. So anyway, just think about what are those little things you can do in your workplace. So another question here, the National Academy of Medicine's conceptual model identifies individual factors and external factors that contribute to burnout. True, false? Yay! Y'all are good, paying attention. All right, once again, kind of looking at the infographics that are available. This comes from the ASHP website. We also have a number of webinars, articles, blogs, different things in terms of helping spread the word of what you can do about burnout. And I talked about having the infographics. So I always tell this, you know, sometimes you need to have stuff where somebody will read it. Put it on the back of the bathroom stall. You shut the door, it's there, captive audience. It just needs to be a fairly quick read. So anyway, ASHP, what we try to do is we do have our own resource center. We've got to connect kind of our social media where people can ask questions, what's worked for them. And so if you've got a place to join in a conversation with others, whether it's your place of business or maybe somewhere across the country, I think it's really nice for us to stay in touch. And then one of the things is we recently made this available for all our members, this Headspace app. And I don't know if anybody has used that, but I certainly, you know, when I found it was free, I was downloading it for me. And it's really pretty good. There's the one that I had used before this was called 10% Happier, and it was another paid app, and Headspace is a paid app. But one of the nice things about it, has some guided meditations. And so I think it's hard for you just to still your mind and to do your own meditation, but I think all of us can benefit from guided meditations, and usually you can set how many minutes you want it. So it's not like you're stuck there for an hour. You can do really short meditations. So I would advise looking at some apps for that. The National Academy of Medicine Knowledge Hub, a lot of good stuff there. Here's your take-home points, and I think I'm going to get you all to lunch right on time. So clinician burnout is really a problem. It's a patient care problem, it's a healthcare workforce problem, and we need to address it. When we're looking at our own well-being and resilience, it's a combined effort. We need the support of our workplace, but we also need to do things for ourselves. We have our own responsibility there. And I know one of the things, this says ASHP, but I think all of our national organizations have taken up and have resources for their members. So there you go. We were going to do some questions, but this room doesn't really lend itself to questions. So I'm going to say, hopefully, you all have one strategy that you're going to use to advance the wellness of your workplace. Has everybody got something they're taking away? All right. And then next, individually. Does everybody have an individual thing they can take back? And we've talked about a lot of different examples, short period of time, but there's a lot of things here. And then, I don't have time to address that one about that New York Times article. Wow. So retire. Adult beverages. I'm there. So thank you all. You've been a great group. Thank you.
All right. Well, thank you, Ann, so much. That was really fantastic. So when we think about topics that are relevant and what we can put into practice, I think that one kind of hits the top of many of our lists. So, I jotted a few things as you were talking, and, I think as healthcare professionals, we often, I think we go into the profession of pharmacy because we care so much about others, and it's, some of the little tips of how we can make things a little bit easier for our colleagues, just a simple thank you, or maybe a $5 gift card for them to grab a coffee, and I think we, frequently think about doing those things and take action on that, but equally important is self-care. And thinking about what can we do to help minimize our stress, and what can we do for ourselves. And, I think that the face-to-face time with friends is really important. We're so connected to devices, and, sometimes we're just, we feel like we've connected if we've just sent a text to a friend, but that FaceTime really can make a huge difference in finding your happy place. I think many of us Rhode Islanders, if we see the water, that's oftentimes a happy place. So thanks for all of that. So next we are going to break for lunch. We will reconvene at 1:30. For those of us here in the room, in just a moment, I'll kind of dismiss us in groups so that we can practice our good habits of hand washing, and then while we do that, it'll also allow the hotel staff to get us set up for lunch. For those of you that are participating via the live stream, we will be ending the live stream in just a couple of minutes because we have to end and then rejoin to make sure that it stays connected for you all. Another addition to the program, MJ had mentioned earlier, we will have Jeff Bratberg here doing some Q&A around coronavirus. So that will be from 1 o'clock to 1:30. We will restart the live streaming around 12:45, so giving you all out there in our virtual space the opportunity to reconnect. So with that, we will start getting ready for lunch. And again, we are